So, with this, we'll like to start. What is firm DNA fragmentation? How it is caused and measured? I want any one of our panel to answer this in a very layman language so that people like me and our junior colleagues are able to understand what is DFI and what is how it is caused and how it is measured. Anyone can start.
Yeah, good afternoon to all. To answer this question in a layman's language, so DNA fragmentation is nothing but there will be a break in the strands of the DNA. Either it could be single strand break or double strand break. So that is how it is considered as, and how it is caused and measured is a long answer. I think it's a whole discussions about this panel. So it is measured basically directly as well as indirectly. There are two different
I think
methods.
Sanket, we will give later. First, you just describe what
This would be the
is
statement. There will be a break in the strand, either single strand or double strand. And it is measurable.
And what is, if in any other simple language you would like to explain what is DNA fragmentation? Now it is very simple.
How many of the girls know split ends in your hair? So it's a one single stranded hair gets a split, everyone can understand it. If similar kind of a split occurs in between the strands in a DNA helix, that's DNA fragmentation.
So I hope this message is clear. What is DNA fragmentation? Next question.
So how it is caused?
Can someone tell us? Mechanism by which this DNA fragmentation.
How it is caused?
So there are multiple ways where DNA fragmentation can be, let's say, there will be like intrinsic factors, there will be extrinsic factors. Coming to intrinsic factors, there are a lot again. So coming to extrinsic factors, something like oxidative stress, or coming to intrinsic factors, any defects in spermatogenesis, and any defect in DNA packaging will lead to DNA fragmentation.
Basically, the fragments will always be happening, and again there will be a body mechanism which will regain it. So when they get into imbalance, that's when your DFI will increase. So it's basically when DFI is high, you're having an imbalance over there. So extrinsic factors could be like too much of stress, chemicals, oxidizing radiations, UV rays, and it could be any infections as such specific to the genital tract over there. It could be even varicocele over there, cryptorchidism, and it could be, cryptorchidism could be counted as an intrinsic factor also. And in intrinsic factors, you would have something like any genetic predisposition. Balance over there. Any cancers over there, especially which is located to your genital tract area. So these are the common causes what will result in high DFI. In addition, the most common treatable cause would be your lifestyle factors. Any addictions, smoking, too much of stress, they say type A personalities. So these can be, and we can go on and on about the number of causes. But the basic thing is many of them could be non-modifiable, some of them can be modifiable. The ones which are modifiable are usually the lifestyle factors, which can be easily overcome, and infections.
Yeah, it's very basic, very simple. Reproducers are given to us, not for us. It is for the next generation. So you have to take care of them. What happened in past 10 years, what happened, we are not changed so much. So one thing changes the lifestyle. We go back and see that thing, that is having a huge impact, especially even in male and female factors. So we have to understand that we can't always blame, DNA and science. DNA works what you are eating, which climate you are in. So that we have to take care of them. That is also important. And this we have to tell the patients also. They need their cooperation when it comes to lifestyle modifications.
Coming to the
Just to extend what Akash has said, there are two things: correctable, non-correctable things. So correctable ones are like DNA repair mechanisms comes into picture that can be corrected. Mostly single strand, most of the time. Double strands will remain as such.
Yeah, I was just trying to simplify for you people how the DNA fragmentation can occur. Basically, when every DNA in any cell in chromosomes, they have got histones. Only in sperms, histones are replaced just prior to head cell packing to P1 and P2. And individuals species variations of P1 and P2 proteins are there. And P1 and P2 are very strong compared to histone for a three-dimensional packing of this one. During that choroid formation, when the packing defects are going on, one or two base pairs in a particular strand might get excised because of the extreme torsion. These are the molecular biological reasons. It could be one of the reasons, or P1 and P2, though they are very thermostable proteins, but they do have a limit. So if the scrotal temperatures or other things are little bit beyond that tolerance of the P1, P2, then again they might start releasing the choroid formations, and thereby it can also get into fragmentation at certain part. Like Akash and Sanket said, there are reversible and irreversible damages. And when the sperm is introduced, even if a fragmented DNA containing sperm is introduced into the oocyte, there are corrective mechanisms from the oocyte side also to correct these defects. So not every DNA fragmentation is irrecoverable or irreversible. What happens is, if it is an irreversible thing which has to occur, then the damage must be beyond repair in a normal set down process. That's when it comes up. And that is always dependent on the dose and the duration. So how long the fragmented DNA, the person is living with this fragmented DNA, and in what all different cells, not just, we are looking at only sperm. It could be, if you actually check with the particular person, even other cells must have good number of fragmented DNA in this particular case. We are looking only at the sperm as a steady population. So the person, how long he has been exposed to extrinsic and intrinsic factors, how much DNA damage in every cell it is occurring, that will also reflect in his gonadal cells. So irrecoverable is dependent on the dose and duration. Recoverable is dependent also on dose and duration.
And just to extend what Vijay sir has said, as we rightly mentioned, they are replaced by proteins, not by histones. So just before the final spermatogenesis, these histones are replaced by proteins, very specialized proteins which are conserved throughout evolution. And these again are replaced by histones. Once they have reached the oocyte and fertilization is accomplished, again these histones will be replaced by proteins. So there are 200 cell types in humans. Only spermatozoa will undergo these unique changes. So maybe at the time of this packaging also, there will be a chance.
And choroid formation also.
There will be this choroid formation also. There will be a chance where there will be a fragmentation or there will be break in the strands.
And to add, it's not possible that whatever sperm analysis you read, it will be 100% will be normal. There will be some percent of DNA fragmentation in each and every sperm, whenever we see a sample. So we have to keep that as a broad thing in mind, then go step by step.
I think what we can consider is that DNA fragmentation is the price which the sperm pays to undergo the compaction. Any cell, more so in the sperms because it has to undergo the compaction from proteins, because it is a messenger cell, probably the only messenger cell, which goes and acts in a different body, outside the body. Rest all human cells are supposed to stay back in the body. This is the only cell which will go outside and fertilize there. So this is the price which it pays, and it can have a different impacts at different levels. And one of the ways by which it can increase, and we have solutions for that, is also anything which is static is bad. Life is dynamic. When we say life, it means dynamic. So whenever the abstinence period is going to increase, even that is going to cause increased DFI.
So after that, I think we have discussed so many things about causes and everything. Can we discuss how it is happening? What is the mechanism behind this sperm DNA fragmentation?
One of the mechanisms would be when the sperm is destined for apoptosis. Normally, out of the cells, sperm cells which are formed, normally one spermatogonial cell should result in 4 cells of sperms of type B spermatogonium. So out of this, they say, they have calculated various studies, they have shown that 3 out of 4 cells would actually undergo apoptosis in the genital tract itself, before being released itself. So it's the majority which are going to actually die and get absorbed. Few of the cells which are destined for apoptosis as such, but before it actually happens, they might get released in the tract.
Yeah, it differs from species to species. Humans, it is say 1:4, they say.
1:4.
But it differs from different species.
And I think what is highlighted, the second one, abnormal chromatin packing, which was already discussed in detail about the toroid formation, as Vijay sir and Sanket has already highlighted. And the redox potential, which I was telling initially, it's a balance between oxidation potential and the reduction potential over there. Whenever there is a mismatch, the DFI will tend to go high. And this, especially ROS, we are seeing in terms of ART, reproduction assets, sperm cells. One more area of active research is in cancer cells, because they are going to have very high levels of metabolism. And whenever you are having high levels of metabolism, oxidation will be, the demand will be high for the energy. Increased demand, increased oxidation, increased chances of damage.
To add this, it is very clearly mentioned, sir, during transport they are subjected to this ROS. Even after ejaculation also they are subjected to ROS. That is where, again, another add-on where scopes undergoing fragmentation.
So, in DNA mechanism, we can divide it during production and during transportation. So, there are so many causes. So, now we can discuss, can you discuss the mechanism by which sperm DNA damage happen and it is causes? And what role do lifestyle factor plays in DNA fragmentation?
One thing what we need to understand is the entire panel is about DNA fragmentation. But you know, it's still a bit of a gray area in terms of how much role it has got to play. But it's a very potential area in terms of male fertility, the area where you are seeing, where we are able to correlate the results with it. Because at the end, what matters is what we are looking for, what we are measuring, whether it has any role in the outcome. So as far as DNA fragmentation is considered, the last decade has seen lots of research over here, and they have been able to correlate. And what are the causes? We have seen intrinsic and extrinsic, and or modifiable and non-modifiable. So we'll always be interested more in the modifiable factors. Say aging is also one of the causes for increased DFI access. There are studies which have shown that as the age increases, especially beyond 40 years, there will be increased level of DFI in the male partner as such. But then you can't do anything about it. You can't stop it. It's irreversible. So what you can reverse is the lifestyle. What I told earlier, basically your stress. As Swami sir had told that we have not changed so much in terms of genetics in the last 2 decades, but the infertility rate is going up. There are many reasons for it, out of which one of the reasons could be increased stress and increased DFI as such. So more of addictions, your modernization, globalization. We have imbibed, we tend to imbibe the negative things first. Things like alcohol, increased alcohol intake, not just alcohol intake, but increased alcohol intake would be there. Smoking would be there. So these are basically the lifestyle factors. And I'm from Hyderabad, so it's more of IT boom. People working in night shifts. The diurnal variation as such will not be kept as the body designed it to be. So even that is a common cause. And we have clearly seen that the rates of sperm production or motility is definitely lower in this population who work at night shifts as such.
As extrinsic factor, we see environmental factors like exposure to radiation and exposure to the toxins, and because of work style, as Akash has mentioned, that the person, mostly the people who work at same facility for a long time, then you can see the DNA fragmentation is high in their sperm because of the temperature thing, because definitely there will be temperature high if you are working, like if we see in the patients like who are working as a driver or area where they are exposed to the high temperature.
I think this is, if I'm not wrong, maybe 15 years ago you showed me the data of one of your cases. Like you compared urban population as well as suburban population, industrial region. There are a lot of differences there. You have seen peaks of data fragmentation between them. So maybe pollution also is another factor that could contribute.
Actually, that I measured in 3 areas. That highly populated area with IT peoples, and then normal and lower region peoples. So there are most of the patients IT peoples, low motility, morphology is very less, abnormal, and in lower region the motility and everything was good, better than them.
One of the reasons why we see DFI more in sperms is because it is a messenger cell. The body has removed all the things, the repair mechanisms have been removed. That's why I feel probably why we speak more about DFI in sperms and not in oocytes.
Yeah, because repair mechanism is absent over there.
Absent in all sperms. They don't have active transcription and translation going on.
Yes.
Can we define any one or two lifestyle factors which directly affects the DFI, including DFI?
Stress
There
and
are so many
exposure to
factors,
radiation.
but
Stress and radiation.
And smoking these days, smoking and stress, the two S's, which is very, very dangerous, which causes the main cause of infertility, which is again broken down to cause this DFI.
Inflammatory diseases, which are like diabetes, any pro-inflammatory state can also definitely result in increased DFI because it tends towards more oxidation. The most obesity, diabetes. Obesity is a multifold, again hormonal changes will happen and tend to have more of scrotal temperature as such.
Right, that much. In the first only I said stress and radiation. Two chief components. Radiation, even heat, thermal radiation. The global warming is also responsible for this. And the habit of wearing tight jeans, sitting on non-ventilated seats can increase the scrotal temperature simply. And over a period of time, when it happens for years and years, you will end up into irreversible mode of damages. So, duration, stress, and radiation.
I think there were some papers which showed even people who take too much of hot baths, saunas,
Yes.
and too much of exercise into bodybuilding, where your body temperature is consistently elevated. So when your body temperature is elevated, even the scrotal temperature will be elevated. We had seen one interesting case where there was a person, very healthy, everything fine. He had a count of excess of, say, it was around 40 to 50 million, but the motility was near zero. All reports have come normal, nothing else, no genetic factors as such, whatever ruled out. During one of the review things, we found out that he actually takes parts in marathons. So out of the blue, we just told, try stopping it. And 3 to 6 months later, the motility has improved. So this is one case which I found quite interesting.
Yeah, then, there's a paper, so I don't remember the paper, but where they compared this between the drivers who have this long drives and all, and also with the donor population, like fertile population of this thing, and they found that there was a huge difference between those of normal healthy population as well as those who are stressed for long rides as well as who are exposed to heat.
I think nature knows all these problems will come. That's why sperms are produced in millions.
In the body temperature.
now,
It's like stagnation anyway would result over there. So when you are not moving around, so there will be no lesser of venous return as such. Arterial you cannot stop, but the venous return would reduce, and that's basically they say how your varicocele causes increased DFI as a cause for infertility as well.
okay, so now this is kind of a reverse panel. This question is not for panelists, it is for our audience. Till now we have tried to understand what is DFI, what are the factors responsible, how lifestyle causes DFI increase. Now this panel is open for audience to interact. Do you have any doubt in your mind? You can simply ask questions. Yes, sir.
You're suggesting everyone should stop going to marathon, or what is it?
No. It is not like that. He should
What was causing actually this problem in marathons?
No, in marathons also, the thing is that it is not a question of running the marathon or getting this one. He is still in the reversible mode. He is still in the reversible mode. If he comes back and if it has the habit of taking the...
Sir, it is very simple. Once the production is there, we can go back and start again doing marathon. No
Once the
problem.
baby is delivered, he can go.
No,
Rather once they
the
conceive
problem
also.
is not that.
Once they conceive
After the
also.
marathon, he comes back and sits in the sauna and then takes a hot water bath. He should try and avoid that and have a cold water bath.
So the logic is like that if you run too much, your sperms won't run.
Sir, see, you believe in doing DNA fragmentation test in a oligoacinosperm.
The question is, do you believe in
No.
DFI test
No,
in
sir.
That
oligospermia.
means you are doing DNA fragmentation test only in a normal sperms, right? Normal semen analysis.
This is my point of view. Like, to be honest, like I don't encourage DFI at all because it is not qualitative test. It's
No.
quantitative.
At least,
Basically,
do you believe in doing, if at all somebody is doing it properly?
Sir, you can
Do you
definitely.
think it is to be
Sir, I'll
done in
answer
a
that.
normal semen
Yes.
or an abnormal semen? Already compromised semen.
Semen.
Already that is have some insult from the basis. So it is likely that almost all of them have DNA fragmentation.
right.
So do you believe in doing DNA fragmentation test in at least severe oligoacidosis?
Definitely. Because
No. Yes.
Yes
No,
or
sir,
no?
let me
What
answer.
is your opinion?
Yes or no? Yes or no? Would you like
Only
to
one
do
word.
it in oligoaspermatozoospermic sample or not?
Yes, that's my question.
I would definitely suggest, but I will not
No.
suggest.
My question, my doubt is,
Yeah,
any small insult to that sperm can cause DNA fragmentation.
absolutely.
Yes.
In a compromised semen sample, already there is a damage occurs.
Yes.
So naturally you will have DNA fragmentation. Why should you do semen and
No. The problem is not at looking at that particular thing whether to do it or not. The simplest thing is that even if it is a normal patient who are coming into it, we do not suggest DNA fragmentation in the very first instance.
No.
When we have certain failures and other things and we cannot logically explain by our methods, we try to look little bit beyond our scientific logic and say try to look for a causative factor. That's when it is adopted. And I do not differentiate oligoaspermia or any other thing. If I have to find out a reason for that and to know whether it is reversible or irreversible, I have to make every effort for that. Then it will not be a question whether it is oligoaspermia sample or not. If it comes out with 100% DNA fragmentation, certain sperms could still be there in a recoverable phase. Why not give that chance? So we will definitely do it, but this will be done only when we have got no explainable reasons for us.
Okay.
Just
to extend- not getting it.
Another
Just to extend
doubt.
that.
See, lot of people do, testicular biopsy to avoid DNA fragmentation. Do you believe in that?
Sir, if I can just ask a question related to your first question. What is the treatment that we give for roots until there is no other hormonal or varicocele?
No, that is,
What is the
to
treatment
treat the
we are
male or
giving?
to treat the sperm is different.
No, not that. What is the treatment that is the most common prescribed for male infertility? What do we prescribe?
According to me, there are three types of oligoastenospermia. When you find an explainable, treatable cause,
Yes.
treat it. When you see explainable without treatment, leave it. 70% of the patients with oligoastenospermia is unexplained.
Unexplained, idiopathic.
So all the treatments are non-specific. And finally, when I concluded, I told most of the pregnancies what we get is patient lack, not our treatment.
Yes.
Sir, I was coming to that because what we prescribe is antioxidants.
No,
And I mean,
Not
the
just
most
like
common.
that, see, empirical treatments I do not submit of or either I do not even support of. What he said is correct. See, it's a patient factor, but when the unexplained infertility we are facing and we know that it is oligoaspermia, but despite that, that should not be stopped at that point. Try to look little bit beyond. You have no problems in doing that.
Yeah, just to extend that, sir. That's the reason. If you look at it.
Another thing, now you are talking about this IT people.
Yes, sir.
Have you asked about their sexual freedom?
Yes,
When you
sir.
are talking about that, none of them have normal sex.
Yes. Even that they have outsourced.
So ask them to do that. That DNA fragmentation.
That is why during COVID time we got lots of people got naturally pregnant.
No, I'm not talking that their sexual life is very bad. Not because of they are having hard night and night duty and all. We don't sleep because we are very active sexual people. In our age we don't sleep, only do sex only in the night. And the night you don't. You are very active.
No, the stress levels are
Stress levels are high, sir.
So,
I think we have to give some importance and ask their sexual life. And recently there was an article in our SRM journal to avoid the DNA fragmentation sperms is to collect the semen at least plenty of time before the actual
Multiple ejaculation.
I think it's very considerable.
But sir,
Just to extend one point.
apoptosis can cause actually it causes the
No. You see the sample you give for insemination or ICSI, and the sample you repeatedly do masturbation or sex before collection. That the fresh sample, the fresh produced sample is the minimally
The message of the study is just this.
I
Multiple
I think it's very
ejaculates
I think it will come at the end.
Sorry sir, to distinguish in between this, we are talking of post-marriage, most of the audience are not in that range, not in the profession. So just let's focus on this. So my basic question, after listening all this discussion, I would like to ask you only, do you advise DFI measurement as a standard practice in all semen analysis for all patients, or you will go for selected one?
I believe already compromised group will have DNA fragmentation. That is something happening during the production. I don't think you can correct that. It's already compromised. We are supposed to do DNA fragmentation test only in the normal semen sample when it is an unexplained disposition.
So not for all patients. So whatever like saying not for all patients.
What does our panel say about this?
It is right, sir, because
Very brief and short.
the WHO 2010 manual said that it was placed under research category. But in 20 edition, the 6th edition, it is considered as extended semen analysis. That means already written a very straight line that it's not for all, but indicated cases it is applicable.
It's not under basic but advanced semen analysis, which not all the patients would require the research.
Yeah, can I just add to it? So, Shabani indicates that, see, basically, mild to moderate DFI is present in all the males.
Yes.
Just like mild to moderate varicocele. It's only when it level enters a certain threshold. And the another sad part is, can we explain the fact that the person who has fathered 2 children, when his DFI was measured, it was found wavered in a naughty mode. How can we explain that? Another history was what? Those who had high DFI indexes, their capacity to produce children at very less attempts was much higher. So there is definitely a big enigma amongst it. And the third part is that all semen parameters will tell you everything except the fertilizing capacity of the sperm. And the indications which we give for XL DNA are quite nearly the same. The resurrective measures are the same. So it is still, I think, one of extra dish of investigation left on the buffet table of infertility tests.
Semen analysis is
Concluding.
a negative correlation only.
Concluding
It only
remarks.
tells you about if it is
I
below
would like to
threshold,
add something here.
Yes.
I think this is not something like trial and error. Okay, there are many patients who cannot afford to go through a second cycle. We need to rule out everything. Okay. Now what happens? As I said, you can predict to some extent whether the sperm is able to fertilize the oocyte. How do you know that that particular sperm can produce a good quality embryo? Suppose there is a fragmentation. Will you go back? You will say, okay, next cycle we will do this. Why do you want to do it? I mean, instead, if it becomes affordable, sperm DNA fragmentation test, do it for all. You are doing a semen analysis, why not do this?
I have a little bit of a problem with this. The thing is that in terms of semen analysis, when we are trying to do even with the DFI, the sperm which we say that it is fragmented DNA, we are not using it for the treatment. And the sperm which we have used it for the treatment, we are not testing it on.
So we have to look
it is still a
at
dark arrow.
what are the interventions we can have for this actually. Laboratory intervention, or we want to use just plus sperm.
Yes.
That depends on the
That depends
condition.
on- Yes.
Sir,
It's a
from
gradation over there. You don't have a continuous, it's like a bell curve for any other. It's like a bell curve, like for BP.
Okay,
For
just
someone
now,
140 would be normal.
just stop it here because we have lots of things to go. So, sir, after all this discussion, what I feel is DFI or DNA fragmentation, this is recently gained importance and people are talking about. But as most of us are embryologists here, so for us, a moving motile sperm is sufficient for giving fertilization. So we were least bothered about DFI till few years back. But now, if there is no pregnancy and patient asks question, then probably this is the answer that we should go for DFI. We'll see if it is high, then we will treat and so on. So
it is not an answer. It is basically you will find what is the reason behind them. You have to diagnose and
DFA basically
okay.
is easy for counseling.
Okay, now we'll move ahead. This question, this forum was open for the audience to interact, sitting last bench. Now what I think is I will ask them directly question. Is it okay? Because you are not participating here. This is a golden opportunity. You see stalwarts of embryology sitting here and answering. Anyway, so we'll go ahead with the next this thing. What are the tests which are available for checking sperm DNA integrity? Today's scenario. Any one of you can answer this. What are the tests available?
Yeah, as rightly said, direct and indirect methods. Direct, there is tunnel, which is more accurate, and there is comet assay, which is very difficult to accomplish in the labs in present day scenario. And there is indirect, which is highly very popular. That is SCD, sperm chromatin dispersion test, and also there is SCSA, sperm chromatin structure assay. But most of the labs in the globally, they are behind this SCD, which is an indirect way of measuring the sperm DNA fragmentation. But to get an accurate nearby results, it is go for tunnel.
There is one more big problem that why DFI we are discussing that the measurement, how they measure, that's also matters. There were recent papers says that which is accurate, whether it is direct method or indirect method. So we are not yet standardized that which is good. Like we are trying to pick up which is easy for us.
Specificity of all the tests are different.
Yeah. And we try to pick up which is easy for me, where I can do without anybody's intervention, or an analyst can do everything. So we are picking something by accident and do it. So it is again it's a personal policy that you know which one you want to go and do it.
Over here, what we are saying, right now, the gold standard is considered SCSA, because that is the only one which gives some ranges in terms of treatment is possible, what type of treatment to be given, and it sees what is the potential of damage that the sperm can undergo. That's why they are called as indirect. They are not the actual damage. Whereas for the directors, these are the actual DNA strands fragments which it measures, and tunnel being the most specific one for this.
So with the permission of the moderators, we have a small poll in the audience, like how many of them are doing SCD and SCSA?
Mostly people are doing SCD. Mostly people are doing SCD.
SCD.
Mostly people are doing SCD. I think very few people are.
What about SCD? How many of them are doing SCD in the labs?
What is kits available of SCD only?
SCD.
Most of the kits available.
Dr. Sanket, I'd just like to highlight that when we are doing indirect tests and direct tests, we subject the sample straight away to any stain or methodology, thereby not traumatizing the cell which they are targeting. Whereas in indirect, there are lots of other procedures which we are putting the sperm to a tormented way, and thereby they might be also indirectly responsible for showing the change.
Including certification.
Absolutely, no, not only that. Now suppose the first comet, it is impossible to mimic comet in a lab because you need a flow cytometer which is phenomenally costly, you need fluorescent stains, and even in the SCD method, you have to stain it, interpretation it, variability will be there, staining pattern difference will be there. So there is a lot of difference on leeway on how each individual interprets the result as such. So this is literally I think an enigma between the actual observation and the actual interpretation.
And there is also a sea of difference between sensitivity and specificity of neutral pH comment and acidic pH comment.
Yeah, the stains which you preserve, whether they are properly refrigerated or not, also becomes a part of it.
That's one of the reasons WHO has kept it as only in the advanced semen analysis, not as a mandatory test to be performed.
Yes, sir. I think we must be aware that when we had just initiated the test to set up a DNA fragmentation
Absolutely.
There are many cherry picking points about it. Absolutely, very true. The stain itself, the fixing your agar, what time, what temperature you melt it, how you freeze it. See, there is a lacuna at every step.
And then even after doing all these things, all tests are invasive, and we can't use the sperm for actual treatment.
No, that's
when we don't actually what sperm, with what kind of DNA fragmentation we're using. So actually we need those tests where we can isolate the sperm with a good DNA fragmentation.
So probably in that case, Pixie and all this kind of options are there where you can select a live sperm and can use it. Anyway, so related with your this first question only, this is another question. How do different types of DFI tests is compared with their cutoffs and predictive value for IVF outcomes? Or let it be in a more simple way, which test you prefer and you advise that this is the simplest way of performing DFI and this should be practiced in routine?
See, as such, nowadays mostly the kids and the ease of mastering a technique over the shortest learning curve with the less, cost-effective way of performing is SCD only. And SCD's cutoff value is up to 30%. It is considered as normal. 30 to 45% is considered as mild fragmentation, and above 50 up to 60, above 45 up to 16 is considered as moderate, and above 60 is only severe. According to SCD. But if I take tunnel for that matter, then it will be 5%. That's the sensitivity value there. So if it is above 5%, then it is already fragmented DNA you are dealing into.
I slightly differ with Vijay sir here, because SCD is like every lab has to set their own cutoff values, because I've seen certain labs in Europe where usually Europeans don't believe in SCD and all, but still what they give is 25% rather than 30%. But in India we do keep 30% because for whatever reasons, and whatever is falling in the category of 35, say 30 to 30, 40 will be considered as X category, that is fair to potentiate.
I think what is highlighted on the screen, this values hold good for SCSE mostly, and there are certain labs which take 15 to 25, other than 15 to 30 they take 15 to 25. It's a different thing with tunnel, like already said 5%, Vijay sir said, but what I remember was 10 or 11%, and there are some papers which even say that beyond 11 or 13% IUI will fail.
Yes.
It has a very good positive predictive value over there, specificity, and beyond 30 they say fathering a child is really difficult with tunnel.
This is for SCSE.
Yeah. This is for SCSE.
If I can add, this whole DNA fragmentation was actually brought in initially in Europe primarily to take patients from no treatment to direct ICSI. Okay.
Same happened with the strict Tiger-Berg criteria.
Yeah. So it was directly so that I don't do IUI if there is a DNA fragmentation, directly take them for ICSI.
Directly take them
IV for ICSI. They never said first IV, they said IV for ICSI. But we all know that it does not really make a difference.
So, next question, SDF and infertility. Why bother? If SDF is not doing anything, so why we bother about this?
Just what like Dr. Bashwa said, it gives us a predictive value, whether to go for IUI or directly for IVF. Based on the cutoff values, what we are getting either with any of the tests, SCSE or tunnel or SCD, so that will be like for counseling, and that makes us help to convert the patient. Instead of going for IUI and wasting the time to pregnancy will be lesser when you go directly for IVF, is what I believe in.
And I think many times you need a reason why it failed in the first place, when you are not doing it for all the patients. So when you face a patient, it's not only about giving a positive result, but when you get a negative result, you should be able to explain to a patient. As humans, you seek an answer, why it has failed. Many times you don't have a reason, so this could be one of the counseling tools, what we tell. So this could be used as a counseling tool as well.
But patient can ask you reverse question that why don't you try this first instance that you want to go for SDF also?
So the thing would be like, we can't do everything for everyone.
We can't offer the second cycle.
Second cycle can't be offered.
It's just that we had recently we did a study where we said the compared between SCD and tunnel, SCSE.
SCSE.
So we sent this data, like I don't want to name the lab, and SCD was performed in-house, and SCD was performed outside elsewhere in other lab. I mean,
CASA was performed outside.
Outside.
And
So
SCD was
we got
performed in-house.
entirely different results from all the 3 labs. Like the most comparable one was SCD between our lab and the other lab, but this CASA had a different values. So for example, if there is 11% of the DFI in one patient, in CASA it was like 31%. Like a lot of variability was there, and I think
Vice versa also. And yeah, it's the same
sample.
And
Split turns was
Split. One you do it in-house and one you
send it outside. And there's no relation like, okay, if you're getting 10% in say one test A, the other test is always going to give high. It's not that way, it was vice versa also. So it's two variable.
Samples are around 80.
So is there any correlation between DNA fragmentation with embryo development, quality and clinical outcome? Yeah, BSS. Maybe Swami will start.
I don't think any outcome differences. Probably we suspect that early pregnancy loss. See, we have to see beyond that just only fertilization. We have to see after that the implantation, the singleton baby born. So we are now, why we are concentrating more on sperm and we started, just we used to do some simple analysis, that's all. Because as I told, we have million people, like million sperms, I pick up 1 or 2 and inject. But now we are looking sperms in a different perspective. We want to know what genetics it is having. We thought, it goes and fertilizes the oocyte. Now we came to know that, it is going beyond, fertilization, organogenesis, even in the early development. So the understanding of sperm DNA, we started now. That's why we are discussing, we are having panel discussion in all the conferences. So it's not like a diagnostic tool. We are looking sperm beyond just a vehicle to go and give the DNA there. So that's why there are papers say that there is no outcome differences, but it may be related to the early pregnancy loss.
Yes, Sanjay.
Anything more to add?
Actually, you see all this IVF business, one is oocyte, one is sperm, these 2 gametes. So I think looking at this test, additional test, the main thing is try to give the best treatment to at least the half part, because we can't do anything with the oocytes. Like we can't screen them even for their DNA status. At least sperm is easily make it available for test. We can give the best test, and that out of these 2, one part is in arm, we try to give the best option, best gamete. So that's how it will help. And considering that given lots of studies, and they say that there will be a less blast formation rate with the DNA with a high fragmentation. So exactly how much it is affecting, then lots of elements happen even after fertilization process. The auto repair mechanism is there. We don't know lots of elements after actually fertilization process.
If I can say, there are many papers which actually correlate your high DFI with embryo formation, blastocyst formation, pregnancy rates, and negatively with your pregnancy losses as well. But personally, what we have seen is it does not correlate that much. There is only a relatively higher chance compared to patients who are going to have a normal DFI. So there's an increased tendency. It's not that a patient who has high DFI is not going to have a pregnancy with this. So it's a relative term over there. And many a times we are surprised to see patients who have high DFI, they're able to have a successful pregnancy. Why? Probably because we are not thinking of the other part, what Sanjay said. We are not thinking about the oocyte. The oocyte can repair it.
Capability. And probably this person might have had a high DFI not for a longer duration. So the correction was possible.
Yeah. Basically, if you look at the data, there's a lot of ambiguity, because some papers say that there is an effect of DFI on the embryo development, and some papers say there is no. So the whole crux is this, as a cell balance, I do repair mechanism. There are a lot of repair mechanisms like base excision repair mechanism, light induced, exact induced. So what happens is the oocyte, or at least the embryo, has this capacity to repair the fragmentation. Either it could be single stranded or double stranded. Hence, I think probably personally, I don't think it will affect.
Can I interrupt? Dr. Sanket, I agree the repair mechanism in oocyte is there, but the younger the lady with no other symptomatic problems, their repair mechanism is at the highest.
Yes.
Yeah,
The older the ladies, which problems, the repair mechanism.
And DNA would have also been fragmented by
Pardon me, yes, absolutely. and I don't think a pregnancy, not able to get a pregnancy, you can pinpoint the DNA fragmentation straight away. Because for a take home, maybe there are more than 155 parameters which need to be justified. And out of which we are in a control of hardly 30 to 35 as such.
Yeah, anything old is difficult to repair.
Okay, so to moving ahead, now after what is DFI, how it is measured, what is its effect and all. Now once you find that there is a high DFI, what is your method of choice for ART treatment? As an embryologist, the clinicians can answer, but as an embryologist, if the high DFI patient sample is there, what method you would like to apply for selecting sperm? Or
I would rather go for a least abstinence period for therapeutic purposes. Means multiple. You can ask the person to either to have ejaculation in vivo or he can masturbate, and he has to do that on a 24-hour basis. And when he comes to our laboratory, then he should be able to give us the least abstinence sperm. If he has ejaculated 2 or 3 times, then probably the least abstinence sperm will be somewhat equivalent to a testicular sperm count. So transportation mediated DFI, what we are talking about, indirect ROS build-up and other things, we can cover it up and we can avoid an unnecessary testicular procedure.
Okay.
But if that is not possible, then testicular sperms will have comparatively from ejaculated sperm lesser DFI, so that you will have to take it. If you want to avoid it, ask the person to come with the least abstinence.
Yeah, that's true. Rapid ejaculates definitely hold the trick better.
Yes, yes.
I will make it short. How we practice it generally, already the male part is examined for when the patient is in 5 years. So when stimulation starts, we freeze the sample. That will be as a backup. That is ejaculation. Then we ask every 2-3 days ejaculation. And then just before after giving the trigger, if the count is normal, then we ask a day before the pickup. If his count is borderline, we ask them to ejaculate at the day of trigger. And if patient is able to, on the day of pickup also, we can produce it twice. So second sample always is good. Okay.
So just one. Yeah. So one question: if you find that there is DFI is high, okay. So you want to delay the treatment for that medication, or if you want to do the next cycle, you want to
depends on the patient.
This is a point where clinician and embryologist both needs to be there. And here what maximum people try and say, and what the papers have suggested also as far as this one is considered, the minimum duration of antioxidant and other therapies, targeted therapies are only for 3 months. First, you analyze again. Then it can maximum go for only 9 months. And beyond 9 months, if it has not improved, then there is a chance that it might not improve. Because we have to go towards achieving the pregnancy. So that's the cutoff line. 3 months is the minimum and 9 months is the maximum for corrective treatments. Beyond that, you go for certain corrective treatments.
I would like to add something.
Yes.
There is no point going for antioxidants.
Yes.
If you don't advise the patient, to change lifestyle.
Yes.
Okay.
That's what I said. Targeted counseling and targeted therapeutics, if you have started, then you cannot go beyond 9 months. And in between, you have to decide an interval of assessment of prognosis.
It is like a treatable.
Sorry,
some dialect on treatment, clinical treatment, how much time it should be given? Is there any?
If DFI is high, you want to wait or you want to still go for that direct procedure?
No, to be very frank, I think DFI, especially in the normal ejaculated sample, probably it is something to do with the sample collection. Usually we take it after a long period of abstinence. I think none of the studies has come on that. You understood my question? No? Whenever you collect the sample, period of abstinence before collecting the sample. Actually, we did a few cases. And whenever we wanted repeated the cycle with a short abstinence, most of the time it was very less. I think nobody is giving importance to that particular aspect. And a few cases proved causes of DNA fragmentation is very large, very close. if that's supposed to increase the testicular stimulation, it's a possible cause for then biospermia. These are the few things. Unexplained DNA fragmentation, I am not very sure whether it's any useful treating for these embryologists. Of course, we have nothing to do. Of course, we have to give some medicine. So, see, buying time from the patient, whether he improves or not, it's not our problem. No, I do, see, it's not like that. I will not leave the patient. I will not leave the patient. I will not leave the patient even if 24 months also, because with that, without my treatment also they can see. So there is no question of stopping the treatment.
Specific treatment we are going to discuss on this. So are there any specific treatment or intervention that can help reduce sperm DNA fragmentation?
What you told earlier, modifiable, non-modifiable increase. Wherever it's modifiable, you treat them. You treat the male. If it's not modifiable, treat the sperm.
I have a quick doubt. What is this lifestyle modification?
Don't leave a stylish law.
What is that lifestyle modification?
The way the person is living will change it altogether. That is individualistic. However the person is living, you change it exactly 180 degree opposite to that. That's the lifestyle modification for that person.
What is that change?
Let's say if he's a non-smoker, make him smoker.
So you discuss all the oral treatment and pre-fertility treatment, but we are going to discuss during cycle, what you can do when pickup is done and what you can do for them.
So microfluidics, I think it's past 1 year I've seen the results and it is really good. When I mean to say, when compared to MAX and other conventional methods, microfluidics is promising. Because I've seen better in the development and even, I don't know the percentage, 3%, 5%.
Around 5% better with microfluidics. And MAX, we have seen that it does well in old sample actually. MAX was well in old sample. The reverse can't do MF.
Max is supposed to do better.
Yeah, it does better in MAX.
We have seen almost 800 patients in the last 1 year. We have compared MAX, microfluidics and even DGC. So we got better results in microfluidics.
And PIXI and IMSI definitely cannot take up DNA fragmentation, forget about it. They both can't take up DNA fragmentation.
Any experience on PIXI?
Never tried.
Whatever you do you have a method to select one sperm without DNA fragmentation?
That's what PIXI was
Then what is the point
that's
in
what
doing?
PIXI was expected to be
Then what is the point in doing
I tried good number of PIXI, but it didn't show this.
No, it doesn't correlate with DNA fragmentation because there it is lysotypic,
No, sir.
autosomal enzyme binding.
Sir,
So it is not
PXA is based on receptors, right? Having based receptors. So there are a lot of studies have shown that it's an indirect way of correlating that the moment this binds to this hyaluron knot, then the DFI levels in that sperm will be lesser.
It's too much of indirect. The thing is that hyaluronal binding and the receptor is in the acrosome, not in the nucleus.
Not in the nucleus.
And DNA is in the nucleus. So if the head binds, then the whole thing will go.
No,
It is
to answer this-
traffic wise and two-wheeler, front wheel goes and my whole vehicle will go. That doesn't fit always.
Yeah. To answer this, what they have done is, to answer this, what they have done is, those chromosomes which are bound to this knot, they have done
See,
DNA.
I did a small this one, I took the PIXI this one, of course it was not a purchased PIXI this one, hyaluronal I plated onto it, bound sperms we took it out and we subjected it to SCD, and without this selection we subjected it to SCD, there was absolutely no difference. So binding of the sperm is not at all indicative of hyaluronal binding of the sperm is not indicative of its DNA status.
Okay, so just on a later note, I was just thinking here, one of the method or one of the treatment which can be offered to couple, common ART center, and then because this factor is not working properly, so there is this problem, we have to reduce it. And if center offers some discount, that if this is corrected next time when you come with modification of lifestyle, probably you will have a better sample and we can do it. Just on a lighter side, so you have to give some incentive to the patient. Probably that may work. So just with this, we are about to finish our this discussions after knowing all these in depth about DFI. Now, all panelists, one take-home message from all of you for the audience that what can be done to what you will advise to the patient or to the couple, infertile couple with DFI.
First thing, fantastic. In the last column, avoid iatrogenic damage, holds good for the best. You should have highlighted and bolded that particular thing. Avoid iatrogenic damage. We can talk about DNA fragmentation for days and days, but no, up till now, no one has talked about the iatrogenic damages. Most of the times, like Dr. Kelsey pointed out, iatrogenic damage is actually increasing the DFI.
Anyone else want to add just one few points? Yes.
In case of oligoasthenospermic sample or OED samples and the normal sample ejaculation, so what is the minimum or a maximum frequency of expulsion sample to reduce the DFI?
See, if it is a normospermic sample, you can have it with as short as abstinence of 12 hours. If it is a normospermic sample. In oligoastheno and other things, 24 hours to 36 hours.
If normospermia, no female fertility, I will not suggest mother. Why to do DFI? Normospermia. Because I give person.
Yeah, no, DFI. Its purpose is what reduce. Shorter abstinence period we are talking about. So if it is normospermia, you can go for a 12 hour.
So this is one take-home message I would like to give.
Yes.
If you are planning to do PICSI or any procedures like that, be very much aware, like for whom you should do it.
Yes.
Don't suggest PICSI for a patient who has 99% hit defect and then who has a count of less than 2 million. You know, like you are doing more harm because the embryologist is going to spend a lot of time looking for a sperm which has bound, and then you know, like in fact you are doing more damage. So any test, even if it is a simple PICSI test, be very well aware for whom you have to do it, for what kind of sample you have to do it. That's one take-home message.
Yeah. What I would say,
whom should we do it?
Yeah.
No, see, you should have, you should have enough sperm, enough motile sperms, and then like you should be able to choose it easily, and then this acts as an additional method of selection.
That's what I said. Avoid iatrogenic damage.
The whole idea is, if you have good sperms, you have sperms now.
No, but then it gives you an additional this thing, like without spending much time on the selection, because like the key is you spend less time exposing the gametes. That is the key. Forget about DNA fragmentation, forget about anything. Yeah, so if you have to do that, you do things within that realm rather than just like using these tests, and then the embryologist will be looking for a sperm and the whole ICSI process will take more than 10 minutes. So you are causing more damage than DNA fragmentation there.
Yeah, basically see, medicine is not ready-made, it is tailor-made. The moment you try to apply any technique for everybody, all the population, probably you may postponing their success also. So and as a scientist, as a medical fellow, we should have a knowledge that it is not for everybody.
That is the key, sir. Because, for example, when we talk about, what little experience we had on MC, what we're doing is like, what is it? Morphological selection. So where should we do? In teratosis fermentation. But what we understand is when the sample is very bad, we are going to select a reasonably normal sperm of the majorly abnormal sperms. So actually our outcomes are not good. Our outcomes are better in which conditions? Where we see a largely normal looking sperms in a regular magnification, but when you are actually doing a high magnification, we are able to find out small abnormalities which are otherwise not seen. So the impression that we take, and we try to imply this on all group of patients. Because every technology is for a certain group of patients. So actually what I asked madam, even though I asked in a very funny way, but it's actually we still don't know. We are trying to do everything possible from our side to improve the outcome. It's not that we are doing it unintentionally. So when we are doing something, at least try and do something which is not very expensive for the patient. At least it's not proven. So I think in the current scenario of the lot, microfluidics.
No, we all agree that Heisenberg's uncertainty principle is an universal principle. The more accurately you try to detect something with equal inaccuracy, you will be spoiling something else.
But even Pixie, like even there is no significant result in outcome. But moreover, Pixie, the hyperactive sperms are there which are heading towards the hyaluronan binding dishes, and they are very vigorous in motility. And it's very difficult to pick the sperm from it.
See, I do understand there are some technical difficulties with respect to each and every technique. But when they say that hyaluronan binding is an indicator of DNA fragmentation and being less DNA fragmentation, it looks stupid to me. Because there are no receptors on the DNA for hyaluronan that is there in the acrosome. So acrosome binds, sperm is fine. Is a wrong notion.
It's an indirect method.
Means that everybody is having brain.
Okay, so with this I would like to thank all my panelists, thank Dr. Katera for giving this opportunity, and an important announcement Dr. Katera just told me. This is for students. For your next semester exam, a specific question paper has been already set for DFI, so be prepared.
Thank you, moderators and the panelists. It was a wonderful discussion. I think we can go on discussing. We agree to disagree on a few things. Everyone has a view actually, how you look at it. But two things is that actually whether you want to do DNA fragment, you have to choose the right fragment. And what is the intervention? So, it's a diagnosis, and then you have to bring down the cost of the testing kit. Actually, if you are interested, you can go to that cost. There is something which is reduce the time of testing DNA fragment. Thank you. Since we are running out of time, we have two more panels. And we have to, in between insert that, little bit of a short video actually. What I suggest is you are not having a tea break. You can actually go out and get your drink and then sit here. We'll continue.
Once again. No, sir. Thank you.
No, video.
Now the next panel will be on advances in embryo culture and AI. This will be moderated by Percy, Aspier and Somina. And I'd like to invite us to be on the stage. And they also request our families to come onto the stage. Vijay Kumar, Matsudan, Sanjay Etnale, Dr. Ravi Nirvani, and Dr. Sujata.
Just wait for 5 minutes, reassemble, then we start. They want to bring half of the crowd out.
They were told actually before announcing this. You quickly grab a cup and come and sit. That's what he said. Just quickly pick it up and come back.
Yeah, there is nothing outside.
Okay.
Hello. So we are starting this next debate. It's the discussion on advances. I'm sorry, it's a panel discussion. It's advances in embryo culture and artificial intelligence. Now you must be all aware that the success of your ART outcome is directly proportional to your culture conditions, because the bottom line lies is that we have to mimic the conditions in vivo and vitro together. So my first question to all of you, to how near accuracy can we exactly mimic the two conditions? Let's start from Vijay first. To how near accuracy can we come across the nearness in vivo and vitro conditions?
According to me, in embryo culture as well as this one, we are not even 30% as efficient as nature.
Okay. So where do we lack?
We lack in various aspects. We are in the end of the conveyor belt. Neither the gametogenesis is in our hand, nor the wellness of the gametogenesis is in our hand. We can only hope whatever is there, out of it, what we are trying to do is select the best among the lot. We are neither improvising, we are not doing anything. Whatever is there with the innate capacity, among that lot we are selecting according to our this one of the best. That's it.
Madam, my question to you, how according to you are the stimulation protocols, their method of implementation, dosage selection, do they really optimize the oocyte quality?
The stimulation protocols, if they are optimizing oocyte quality, this is very, very doubtful. Because, see, like this needs a highly individualized approach, which is very difficult to know. And you know only the outcomes. You give a particular type of stimulation, you get oocytes. Only after getting the oocytes, you know that, like you can correlate the two. So I don't think we are, anywhere near optimization of the oocytes.
So the selection, the highly purified, the urinary, do they have any role to play?
Definitely it has a, that actually decides the fate of the cycle.
What's your opinion, sir?
That's true. Like it's ultimately an artificial modification of the system. Like stimulation protocol, it's not natural. A lot of things are altered physiologically also. So definitely there will be a compromisation, and the best protocol individualized, they select, that will give you the good output.
Your opinion, sir?
If we knew exactly what is optimizing, then we would be having same protocol all over the world. What I think. So we don't know exactly what is working, how it is working, to whom what is working.
No, because we have been seeing a lot of debates. Initially, it was urinary versus recombinants, highly purified. So in what way are those debates justified? Because the reason why I'm asking this question is because the next thing we will be coming is to the culture condition. Now the culture condition are not a magic wand. This will give you an optimization of irrespective of the quality of your oocytes or gametes are. So this is the reason why I want to ask you that if we culture when the suboptimal, optimal or superoptimal oocytes, how important a culture role is to play? We just start from it.
So the whole aim of our culturing is to preserve what is there in it from deteriorating. If possible, it could appreciate. It could have a positive impact onto the lot of gametes what we are having, whether they are poor quality or this one or whatever it is. But it should not, our culture condition should not deteriorate the intrinsic inabilities of the gamete or the embryo much further. In fact, either it should make a static effect or a little bit of improvisation from its this one. So our culture condition should mimic that part. And like you said, we don't have any control onto the quality of the oocyte. Even with best of the individualized stimulation also, what we can ensure is only good number and good retrieved oocyte to mature ratio. We cannot decide the fate of that particular oocyte either. So we are far away from that part. So we are makers, we can't be choosers.
So basically when we just do embryology lab as a wall between the two sides, the clinical and the embryological, the best part of the embryology lab is that what you get, you culture to your optimum best. At the same time, we depend upon the clinicians to help us provide with the best, which we are going to deliver the best.
Yes.
Can you highlight on that?
So the mantra is, you cannot make a good embryo from a bad oocyte.
Absolutely.
So if it's a bad oocyte, it remains a bad oocyte and it will become a bad embryo. There is no way any culture condition or any embryologist can make a good embryo from that. That is something which has to be understood.
So coming to the question of bad embryo, many a times you must be shocked that certain bad embryos which we have literally written off. How often do you think they have sprung out positive results?
See, this is
Surprises are there.
One thing we should understand is there is no 100%. Okay, so for example, if you are getting bad oocyte, bad embryos, what is the percentage of these bad embryos resulting in pregnancy? Maybe 10%. But if you are having good embryos, what percentage of that result in pregnancy will be 50%? So there is no, like you cannot, as long as there is some life in the embryo, you can never write it off.
Okay, fine. See, in general, I usually keep on saying this. You are used to this statement. 80% of a class follow strict SOP. 20% are either above average or below average. But neither that 20% represent the entire class, nor this 80% represents the entire class. That's the truth. So we have set up certain timelines for our assessment to grade it as a good or a bad or a poor embryo. So that particular timeline is based on the 80% assessment, not on the 20% outperformers or underperformers. Sometimes they do also perform. Overperformers fail and underperformers succeed. That 20% cannot be a universal gesture. That's what we have to understand, and we have to be with the 80% where we can have more of a predictability.
And how important is patient recruitment criteria in helping us judge the good quality eggs, or substantially quantity versus quality or quality versus quantity?
Patient recruitment is important, but you tell me the practical scenario. Do we have any choice? With the kind of competition around, you know, like even if you know that this patient has 0.1 AMH, you still have to be sending away that patient.
Yeah, and the second part is today out of the limited patients we get, I think more than 85% must be about 35 to 37 years of age.
Yes.
With multiple cycles, poor AMH and lots of complications.
Yes, 35 is sweet 16 for us in IVF.
Yes, literally. But sometimes the more sweeter the things, the better hard is to digest them as such also at the same time. So what's your opinion, sir?
Even nowadays, younger patient with low image we can see.
Absolutely.
So when patient comes, if suppose you directly ask them for a donor set, it will go to the another center. Okay, so you have to treat them. You have to, it's not by chance, but definitely the patients like to have or to to hope to have their own baby. Okay, so ma'am rightly said, we don't have choice.
Sir, what's your opinion?
Agreed, sir, everyone. But it is all depending on how the consultant choose the stimulation. What it is coming into the lab, we don't have any control on that. But what is there inside the lab, that means the optimum culture conditions for everyone, it is same.
Pathetically, the problem is that neither clinician nor we can do anything. Because gametes are prefabricated. It is already fixed. Our biggest problem is that our raw material is biology and it is having life. We can't stop anything, we can't pass anything. So I tell my clinician fully, sir, whatever you give, we'll get it back.
So we are in a nutshell modulating into perfection.
Yes.
So coming back to how we modulate to perfection, the recruited gametes which we get irrespective quality, quantity, and we culture them. So how important you be giving the process of media equilibration in optimizing your culture conditions? Starting from you, sir.
See, all the medias are well formulated now, and only thing we have to set according to the lab wise. Like we have to believe only on the osmolality and the pH. These are the main important, which controlled by the CO2 and temperature. So these things are maintained properly. I think the output with a good quality oocyte or gamete will give you the better results.
Pass on to next.
I would give 1000% importance to media equilibration and preparation. I always tell people who come in new to our system that I don't care what your skill in ICSI is. Because when you inject 10 oocytes, you might, like damage 5, but you will still have 5. But then if you don't prepare one dish well, you are going to damage all the oocytes. So I give very importance to media preparation and equilibration.
Why I am giving this example of media equilibration is because ideally media equilibration was done in tubes, 14 ml tubes with 2 8 ml capacity with 4 ml shoulder space, 18 to 20 hours prior. But many times we see even 60 ml bottles straight away kept in the incubator with a loose cap. So aren't we compromising culture in such case?
Definitely.
We all say definitely, but 90% of the labs we see the same scenario.
Yes. People do not practice what they preach. That's the problem. We can't help it.
The bottle is taken from the fridge, it is kept in the incubator.
Yes.
After you take media, you put it back in the
Correct.
fridge. Again, the same day evening, you take it from the fridge and you put it in the incubator.
So this is the most nasty way to equilibrate.
Yeah, that's what. People don't practice what they preach.
It's a criminal.
Criminal offense, literally. Because you are creating a crime as comparable to murder as such.
And this is the very first step in IVF.
Absolutely.
This is the very first.
Media equilibration is the first key for your culture conditions. You falter in it there and you falter entire process.
And what about hippies media? What care and caution you take?
In hippies media, do not expose it to carbon dioxide. You keep it in a tight cap and it has to be
Don't
temperature.
keep them like hippies, okay? Keep them.
No, definitely, because hippies media also bears the crux because your flushing media, your sperm preparation media are all basically hippies media. And hippies media, especially the flushing, since it has the same osmolarity as the follicular fluid, is the first media which will come in contact with your OCCs. And if the temperature is not maintained, as which will maintain nitrogenic damage, you mess up the spindle in the oocyte, thereby subsequently compromising your
entire cycle.
Even then the hippies media, instead of keeping it in the CO2 incubator with a tight cap.
No. That's even not allowed, sir. Even cap media, because the same question I had asked to some
cap companies, certain amount of population.
Yes, because they say the percentage carbon dioxide in a CO2 incubator is under great pressure and strain. So the penetration is quite large. Even from your water which you feel it is airtight. So even the misnomer of you keeping hippies media tight is absolutely a wrong thing to do. So it should be having a separate incubator, bare incubator at 37.
A bare minimum equilibration time for a hippies or this one culture media is 8 hours. Bare minimum. Maximum of 24 hours. But if you have exposed your culture media beyond 24 hours in the incubator, you cannot use it for culture purposes by any chance, because it would have already diluted its glycine and glutamine concentrations to a greater extent, and that will be detrimental again.
So what according to you is hyper-equilibration and hypo-equilibration?
The hyper-equilibration is people who keep for 48 hours plus the culture media in the carbon dioxide incubator and think that it can still be fine. And the hypo-equilibration is only just 3 hours into it, or some flying people who, that's why I was literally shocked, and I think we both were there. He just took the carbon dioxide gas directly from this one and he gassed it, then he pressed it and put it into microwave oven and switched the pulse for around about 100% power per 3 minutes. Then he said now it is at 37 degree and the gas is also been done. Such jugaad is not going to work in culture.
See, a few days back I had an experience. Like my junior, she prepared the dish. There were 2 cases were going on. One case is she prepared for tomorrow case, she prepared a dish. And meanwhile, ICSI has happened. So she has mentioned the date 9/11 and the ICSI was done nursing. And she prepared the dish for the tomorrow.
Next day.
By mistakenly, what I asked, she was not there. I think by mistakenly I thought she has prepared it yesterday itself. Then I placed the embryo. I don't know how many has it turned up to out of 6 embryos.
See, this is what I am saying. Sometimes you do have surprises and they are good surprises. By chance you had a better result, so you are talking about it. Had it been this one disaster, you would have fired the lady on the very first day itself, very next day itself. So these surprises should not be our principle. We have to go by principles of generally accepted 80% norms.
Generally, embryos have a good plasticity. They
get adapted.
But that depends upon their causes. If it is a good, in a young patient, a good oocyte, and if you are exposing it to higher temperature, lower temperature, it might survive. But an elderly patient with very poor sperm, a compromised embryo.
Or maybe an ART is done in which a lady's female factor is not there.
Yes.
That means she is producing
Yes.
good quality oocytes. Correct.
Many anecdotal incidents are there where they say that incubator was turned off, there was no temperature control for 3 to 4 hours. I got twins from there, and then they will say, like all kind of anecdotal things are there. But then
And we all have experienced such anecdotal things, but that should not decide our practice. That's it.
Anyway,
extended to that,
yes,
in our laboratory we follow that if any media, that means especially the culture media, taken out of the fridge, either it will go into the incubator or into the dustbin. So it is quite weird, but still we are practicing and we are getting good results out of it.
No, I would not even say good results or anything. We are satisfied, at least we can go back and analyze if something goes wrong.
Yes, that SOP is
I am explainable there. I am transparent and explainable.
One more thing, we will be able to analyze it only if we document it. Anything not documented doesn't occur, and it is not prone to analyze. Anyway, the next question is that since the single-step media has caught everybody by storm, many a times we have seen, whether it's in a droplet culture or in a large culture, say 1 ml in a center well dish, we have a tendency to overpull the embryos. Number. Now, some people say that in spite of you overpulling and in spite of you using a single step, you should refresh it after 24 hours. Is it necessary?
No, it's not after 24 hours. Minimum, you can, the single step medium for formulation, the potassium simplex optimized medium, their formulation and the alanine glutamine what they use, they sustain it for roughly around about 72 hours if the embryos are in culture.
Yes,
that's why I usually say at every 60th hour you have to refresh. If you want better consistent performance of your embryo culture system, at every 60th hour you go for a compulsory changeover, complete changeover. Some people have got the habit of adding, after the time-lapse incubators came up, the slides are very expensive and loading the time-lapse capsule is a trick in itself. Most people fault us. So what do they do is they just take some 10 microliters medium from above the embryo and take a fresh 10 microliter medium and they replenish it there only. So they do this trick. This is again a jugaad I am saying. If at all if you are changing this, then you have to change the complete refreshment only. And that should have the maximum time limit allowed for a particular person is 60 hours. At 60th hour you have to change the this one. See, their embryos are continuously growing. They need nutrients. They need this one. If you are not supplying them the food and thinking that whatever 30 microliter you have kept will be taken care till 120 hours, it's like asking a person to have meal on the Monday morning and then the next meal will be served on the Monday morning itself.
Now, another suggestion.
But what happened in case of, with mass culture in the formal dishes?
Mass culture, I am not a proponent of mass culture. I just hate it. So I cannot answer that question.
Sir, why this single-step media came
No,
into
sir,
the
in mass culture you mean to say in a center where we at least 4-5 embryos together.
Even the formal dishes with the open culture.
If 4-well dish, ideally you would put 1 embryo in each well.
Formal dishes.
4-well dishes, there are 4 wells, right?
Yeah.
So usually we put 1 embryo in each well, so we can exactly monitor them as such a library effect.
Say people have been doing 2, 3, everything, and they are talking too much of paracrine factors, autocrine factors, all the explanations have been taken care of. But in my life I have never practiced group culture. So I cannot talk for group culture, whether it is advantageous or disadvantageous, because I have not done it. Me speaking on it will be not right.
So in the sense, what I want to ask is, since you are...
No, how many?
Vijay, what I am asking is, in case when you have mentioned about the changeover of the media, like after 60 hours, okay, in case of these 4-well dishes, even with the culture with the 0.5,
yes.
What is the minimum like volume you suggest to change over
See,
again.
minimum volume per embryo is that we call it as embryo density. Per embryo, how much volume of medium is needed is 30 microliters is accepted now. People have the habit of making a 50 microliter droplet and keep it in there. So it is 20 microliter excess. Excess is fine, but you should not make a droplet below 30 microliter per embryo.
See, because sir, when you stretch open an embryo, you have to go by its curved surface area, which is quite large as such, because it's a sphere. So automatically, when 2-3 embryos are pulled in a droplet of say 30 microliters, still there's a large surface area. And as an embryo grows, the energy demands increase by the minute. So that was my second question which I wanted to ask you.
Dr. See, there is one more thing where we have to, think of replenishing this media. It's not only for the nutrients in the media,
But also built up ROS and other factors you have to take
Commodification.
Yes.
Exometabolites in a nutshell.
Not that, even the environmental
Environmental
contaminants,
also, yes.
because you have an oil layer which acts as a sink, and that, whatever is aqueous
ROS,
gets into your
That's exactly the next question.
Yeah,
how,
it's the
will
lifestyle
you,
change.
how will you just increase the efficacy of oil? Whether incubation, see, because oil being denser, it definitely needs more time to even incubate as such. So don't put on the media and the oil at the same time, because volume-wise, we usually have a tendency of keeping the whole oil bottle. Right?
Yeah. See, this one is oil requires almost 24 hours equilibration in a proper distribution. So the best way for me to do is I just keep oil in the morning in the incubator, and then in the evening I will prepare a dish for the next day morning and coat it with oil and keep it. Then the oil, whatever equilibration would have occurred, will be transferred to the droplet, and overnight incubation, even the oil and the media droplets, everything come to an equilibrium.
Because diffusion of carbon dioxide in media without oil is faster. Oil through oil is a little difficult. That's why people take the closed dishes or overlaid dishes outside. Yes, kuch nahi hone wala hai. But no, when you keep the dish back, the re-equilibration takes more time than that. So, do you prefer incubation of oil or equilibration of oil?
Incubate and then equilibrate.
No, but automatically they won't go together, no?
No.
When they incubate, it both happens at the same time. So, whether you tighten the gap or you
loose gap.
Yeah. So, oil is to be equilibrated.
If you are using oil for ICSI, then you can keep it in tight gap equilibration.
Okay.
Because there you will be using deepest media in a much smaller volume. So your carbon dioxide equilibrated media can change the microenvironment around the deepest medium quite faster if you have kept it in that. Otherwise, you can keep it open gap or a loose gap oil for equilibrium.
The next question is for you to answer. The bench tops and Parvin time lapse as far as progressive growth.
See, here we are looking at two different things, right? Like in benchtop, it is just culture. In time lapse,
It's monitoring.
It's monitoring. So, your combination of culture and monitoring, so theoretically, it should give a better outcome, because in benchtop, whatever you culture, you still have to take it out for monitoring. So, I don't think that can be compared. Time lapse definitely might have an additional advantage.
And in media, I wanted to ask you one thing. Now, since I am also a staunch follower of IVF first, now certain single-step media indicate from zygote to blastocyst means you have to do the fertilization in the fertile media and subsequently keep it into the single step. What is your opinion?
Sir, that was what before KSOM came into picture.
Yes.
The potassium simplex optimized mediums, when they were not in the market. That was the time when FERT media was different and this one, because in fertilization, especially if we are doing IVF insemination, the sperms do require fructose.
Yes.
So because of which a higher sugar concentration which was there, and from zygote to blastocyst would have a little less glucose in that particular conjugate. But now with KSOM, potassium simplex optimized, they are working on to this potassium and sodium channeling and their differences. This particular thing doesn't occur. You can use KSOM from the day 0 till blastocyst. But it allows, it contains all the nutrients and the milieu required for it. It doesn't say that you from 0 to day 0 to day 5 doesn't say that you put one droplet, keep one this one in it and you continue it there. You have to do refreshments. That means you need not have to buy, stage 1, stage 2, FERT media, cleavage media, blastocyst media and keep on changing with it. This same media you can make dish.
Same media change
every day or change once in 60 hours.
So apart from the scientific, we also have economical reason. So because what happens is if you are using a single step media right from the beginning, your oocyte pickup procedure actually demands lot of media. In fact, as per our SOP, we use around 4 ml of media for pickup. But whereas culture is done in droplets, which like all droplets put together, it can you can
get up to 1 ml or 2 ml max.
So like economically, it does not work when you have to use media for fertilization and also for embryo transfer, because embryo transfer also requires more media, where the dish you have at least 1 ml of media for rinsing and all that. So in our system, what we do is for pickup and embryo transfer, we still use sequential media like FERT and BLAST, but for culture we use single step.
Coming back to this flushing, I actually know some doctors, which even you must be knowing, they don't use the flushing media at all. They absolutely do a dry pickup. I was amazed.
Nowadays, most of the people do dry pickup.
Injection media, they don't need to do with the flushing.
No. Flushing
is when they charge the needle.
They charge the needle.
Actually, efficacy of the pump, the pressure point, so that they charge
in the tubes, and they will be aspirating it into, instead of blank tubes, it will be aspirated into media-filled tubes. So that's the flushing part he is talking about, not the flushing of the follicles. Reverse flushing of the follicles he is not talking about.
Basically, follicle flushing nobody must be doing, because even double lumen tubers are no longer available.
No, they are very much available. Very much available.
Much less.
No. Basically, certain clinicians practice flushing only. They restrict it to that particular case where they have less because they don't want to miss the chance that we haven't tried much or it was in a different coach or anything. That's fine.
Now the most important question, which till today is even baffling: dry versus humidified. Do they really matter? Or once you layer with oil, every incubator becomes a dry incubator?
It does matter. See, I was a proponent of the dry incubator. To be very precise, for the first 14 years of my embryology journey, I have done it only with dry incubator. Even at the water tray, I used to throw it off and I used to run it.
But your media equilibration does deteriorate.
Yes. Now the situation is, when you are using dry incubator, you have to cover even your equilibration media also with oil and keep it. The tube also should have oil, in order to prevent that minimum droppage in the osmolarity. But once when I had hand onto my osmometer, that's when I started noticing, I started grading the thickness of the oil layer. If I take 1 ml of media and if I put 0.5 ml or a 5 millimeter layer of oil, the evaporation rate was still faster in dry incubators. Whereas with 1 ml, the equilibration time increased. So this gave me an indication that humidified incubators work better. At least you can get rid of that particular thought process. You don't have to do unnecessary research on the thickness of the oil layer you are supposed to put.
What I saw was in many of the bench tops, initially they were dry without the supply of humidity. Now just to counteract the propaganda that they are not humidified, a tube was added, a small bulb of water was added. Now common physics tells us that through a narrow bulb, how much of the vaporized water is going to infiltrate
the maximum humidity they reach in that particular modification is 55%.
Absolutely.
Which in a general environment will be normal at that particular level only. 55 to 60% humidity will be there. In any given room, even with the AC on, that will be the normal humidity percentage. So that will be there. It is just a mental satisfaction a person achieves out of it. The thing is that if you are having a dry incubator, you have to really work up the kind of oil you are going to use. You cannot change your oil brand. Once you have a dry incubator, you have to stick on to one oil brand because that you have tested, and you have to keep a minimum, you have to write an SOP that no matter what is your droplet of this much layer of oil should come above the droplets. That has to be mentioned. Or even the volume of the oil what you put per dish should also be clear on that part. And that you have to maintain.
Difference between heavy and light oil.
Yeah, there is.
Yes.
There is.
Especially for time-lapse incubator, it's better to use the heavy oil rather than the light oil.
But usually we prefer paraffin oil.
No, both
are
are
available.
same. Both are paraffin only. Mineral oils are heavy oils, usually what we call it as. Even that comes from the petroleum industry only. The heavy oil is little denser compared to light oil. The problem with heavy oil works like a wonderful sinking agent for the VOCs. It accumulates, whereas light oil will not accumulate that.
Yeah, because
There's also another problem that handling heavy oil is a bit tricky.
Yes.
Because when you are using a pasture pipette, a plastic pasture pipette,
It just
this
get
gets
clogged.
oil.
They get clogged.
Clogged, and then it takes a very long time. So
And if you force it, there are inclusion of bubbles. Yes. And the bubbles encountering means it's a nightmare.
The wide more pipettes we can use it for.
But to be very frank, how much of an importance do we give towards oil? As long as oil is oil, we always say that.
So we have to give importance because very recently, like last year also, we had a call back from the company, like a particular brand of oil. And then almost 400 and odd patients of ours were affected, where the cycles were completely washed off because even with the best quality oocytes, we did not get any embryos, arrested on day 3, arrested on gastrocystic. So oil is very important.
Yes. So your question, you told me half bottle used post refrigeration. How productive they are? I would say zero productive. What's your opinion?
Depends on the duration after opening the bottle actually.
Then after that whole thing will be stored in plastic. But bicarbonate buffer, I think to re-refrigerate them, it's...
No, it is not re-refrigeration. The thing is that the first opening they should have aliquoted in the proper way.
Yes. And then
they have taken only the required amount of aliquot repeatedly and they have kept it. So that is re-refreezing.
That one room temperature surface. Sometimes they can put on the heated surface and there is evaporation. So aliquoting media is equally very delicate procedure, important procedure as any procedure in the IVF.
Now the next most important burning issue, artificial intelligence or natural stupidity.
Natural stupidity is my selection rather than artificial
I would
intelligence.
like to use artificial intelligence because like what happens is this is an evolving science. We should not judge a technology with whatever we have right now because this is artificial intelligence version 1. But then with a lot of data coming, definitely it might help because see there is a lot of subjectivity in manual testing. What Dr. Vijay is doing is after 30 years of experience, right? Like his experience cannot be compared with a person who just finishes her masters and getting into the IVF lab.
But not only that, see sometimes even when Vijay says 4-cell grade 1, I might say 4-cell grade 2. And for the same embryo, if shown to Vijay after 5 hours, he might find that one culminated into 2. But what your artificial intelligence does is it picks up, designates it, and the designated criteria stays put. But then does it mean that we are simply referring to a massive database and comparing the photo of our existing embryo along with the one in the database and selecting it? What exactly does this AI do?
No, see, currently the AI technology, whatever we have, it's just looking at a picture, which is not a two-dimensional image. In fact, there a manual assessment will be more accurate because embryologist is seeing it at 3D. Like you can rotate the embryo, you can see things which a picture cannot tell. But then recently, I was listening to Dr. Viral Aideen's talk, where he had mentioned that in the microscope they had added extra prism so that the picture, whatever they get, right, like that, it adds an extra dimension to it, where the AI becomes more accurate.
And AI will be cherry picking so many minor things which unfortunately our human eye is never able to do it. Intricacies like micronucleation, this, that. So time lapse also does the same thing. So that's what I'm trying to tell you, that automation, does it impact the consistency and the accuracy of the various assessment criteria? Sanjay, it's your turn to speak.
Actually, I was about to speak earlier with this question. As you mentioned, the 4A and 4B, at your perspective, perspective, that currently AI is at machine learning stage. So whatever data is given is different setups, different microscope, different lights, different angle. So to make it uniform, there is a, I think, long way to use it. And after that, we should have the same setup as it has been, what we say, taught, or it has been actually the developed. Yeah, yes.
So instead of accepting completely into the AI, we can give our trials from our side also, right?
So we'll slowly we channelize it into another way before we straight away jumping into
correct.
another mode of action.
Yeah.
So the question is, does our intellectuality, does our observation skill, is at par with the AI as such, or AI is a shade better than us, or we interpret it more as per our knowledge or interpretation or years of experience? Which one is better?
Experience is better right now.
Experience is better.
Right now, maybe after data collection, whatever machine learning we are feeding into the machine, probably in the long way, we may need to depend on the AI.
So there's one thing, see, when we started IVF, right, like we had enough time to get experience, enough time to get trained. Like there were not cases like back to back. You would definitely have a day in between, or sometimes in a month you will have only 2 pickups. So you had a long time, there was no pressure on us. But unfortunately, that is not the case with the embryologists who are coming into the system now. From day 1, day 2, they have to start doing actual cases. In that case, it becomes very difficult, it becomes highly subjective, the skill level is varied. So definitely you have to depend upon some technological, like involvement there to give some quality service.
Yeah, that's why we call ART as assisted reproductive technology. We never call assisted reproductive biology. So more and more technology will come.
So we are never ensuring a result, we are just optimizing the chances of a result. So coming back to this, when they say the AI selects the best embryo, now best is what way best? Appearance-wise, morphokinetically wise, because AI doesn't have any parameter which does the genetic screening.
So, but then manual screening also...
It's also morphokinetic only. It's morphokinetic.
But then at the same time, we tend to bend a little more towards AI, thinking of which is the best, it is definitely going to give you the best embryo. Agreed. Best in all characters except the genetics. So the implantation till today remains a question mark.
Sir, that is a marketing talk. That we select the best embryo is a marketing talk. Let us keep it aside. The thing is that the thing is very simple, that we are also doing manually morphokinetic assessment.
Yes.
At this time interval, what is the morphokinetic?
So we are doing this.
We are also doing morphokinetic. AI is also doing morphokinetic at the moment. But yes, certain non-invasive probes are being tested at the moment to check certain of the metabolites in AI model as an additional advantageous non-invasive assessment in addition to morphokinetics. But only after we get certain series of this one out of it, we will be able to be
AI is giving
confident.
a lot of annotations and subsequently comparing with a lot of algorithms, and ultimately just telling us that from A, B, C, A, B and C, like now it is your cup of tea to select what it is.
Like
we are trying AI system where the primary endpoint was live birth.
Live birth, very true.
But what happened was, when you look at the morphological score, AI gives a lower score than us. See, for example, when I look at that embryo, when I say it is 4AA, okay, AI gives a score of 65 out of 100. The reason being, the embryo on which it was trained, even though it was a good embryo, it did not result in a live birth. So it is using live birth as the endpoint.
Yeah,
then
not the criteria.
grading this
when I started with my journey of time lapse and other things, initially I thought multiplicative model is the best model. So, but we are not in AI. Somebody is selecting an embryo is a misnomer. It helps in better deselection.
Yes.
At the moment, whatever AI we have, it helps in better deselection. So I started working on with a multiplicative model. In multiplicative model, say the moment you see 3PN, you avoid it as 0, and 0 multiplied by anything will be 0. And at the end, when I started, when you are writing a multiplicative model, how do you want to give the score will also become important. So I made a mistake initially by giving 0, 1, 0, 1, something like that only. So everything came down to 0 at the end of it. So there you have got to, when you are writing an algorithm, you have got to write negative values and positive values to arrive at a particular conclusion.
Now,
if there is 10% fragmentation, then you write it as 1 plus 1, and if it is 20%, write it as -1. If it is 30%, then write it as -2 in a multiplicative model. You should use negative and positive. Then somehow I changed that, then I went into additive models. In additive models, you award a score. If this is there, this is 1. If this is not there, she said 100. So you award one particular assessment, what you are making, a particular number, and you keep on adding. Now there the question is, the moment you can say that if you find a 3 p.m., you award it 0. It should not be there. In additive model, it totals it up and it gives it to you. So you should know the perils of the additive model also. There, the deselection is not occurring. 3 p.m. also afterwards, if it is divided into 6 beautiful 8 cell embryo, you will say that yes, addition 0 is excluded and rest of the additions will be there. So that is there. But what we use in manual system is hierarchical model. So at the moment, if you want to train your AI system, you train it on hierarchical model only. Do not train it on additive and multiplicative models.
Now one question was there. Drawback, I can't say drawback, a lacuna with timers. They keep on photographing stationary embryos. Now what we do is, sometimes when we grade, we just tease it, let the embryo roll.
No sir, no sir. That is a misconception. Actually, it takes, nowadays the time-lapse system, earlier when I started it was 4 levels, then it increased to 7 levels, now it takes 11 slices. From this bottom till top.
But still, in that, because prior models which many had invested into, that was the biggest crux of the issue as such. You are really seeing from this, you wrote it, it might show a negativity on the other side. So there was a
disadvantage exists with AI also.
Correct.
Because AI, you just give up a simple photograph.
Correct.
Whereas an embryologist can roll the embryo.
3-dimensional photographs. So these are annotations and algorithms. Are they always applicable to entire cohort of gametes?
Again, sir, it is 80%, 50%.
Whatever it is, irrespective of age, indications, and pattern.
Yes,
frozen or fresh, that's the biggest challenge.
Yes. Sir, if it is a frozen embryo, a frozen third embryo, if it is not looking good, even manually also we are saying it is bad embryo only. So it holds good like the same, it doesn't change. Annotations and algorithms doesn't change. If with respect to indication, age and any other things, it is universal. You just
but in the time lapse, we have seen that especially early cleavers, those embryos which are cleaving before 27 hours.
Because
there is only benefit we found there.
Nobody will be there at 27 hours to see it.
Yes.
Even accurate, which was not seen by the human eye, is detected by the embryos. So now this is your last question. I mean, sir, you made that very well. Will AI replace the experienced knowledge and the dexterity of the skilled embryologists?
Maybe in the future.
With all this.
Yeah, it's like that robotic XCK neurosurgeon got scanned because some operator should be there.
You are the operator of the robot instead of the surgery.
Of course, AI is replacing everywhere, not only the embryology.
That's the next issue. We were just discussing that robotic surgeries are also creating problems, but unfortunately they are not highlighted.
And there is an operator for it. People don't know whether.
So you have full confidence in that. So are you overrelying or we are bypassing the ethics and counseling?
No, I don't think now we even have the luxury of over-relying on AI. We are still in the starting phase.
Yeah.
So I don't think we are relying on AI so much. At cultural counseling.
That's a nice point where I would like to ask you all, has AI always got to synergize with time-lapse?
Not necessary. Not necessary. Over a period of time, there will be independent AI platforms where you feed the photograph and get it.
Now, what training and resources will embryologists need to effectively incorporate? Otherwise, any common people हमारे वहाँ जो lab साफ करना वो भी कर बोलेंगे this is the best.
I think what we need is that mindset. That is the first thing. Training comes much later. Like your enthusiasm to adapt newer things, to learn newer things.
Can I just interrupt in this? But the problem is with youngsters. Provided you instill into me a confidence that I am going to train you, then only I will challenge my mindset. It's like I scratch my back, you scratch mine.
Say for example, like we were, as I said, we were trialing a AI system, which would require taking pictures, cropping the pictures, loading it into the system, and entering all the data. So this is additional work. You know, so they were doing it for 2-3 days, and the 4th day automatically they just stopped doing it. Then after a week or so, when I asked her what is the update, how are we proceeding? No, we stopped it at that time. Why did we stop it? Because we don't have time. You know, it's not like you take a picture.
Embryology and time work never go hand in hand. They are always inversely proportional to each other.
Aptitude and attitude cannot be taught to anyone. They have to
inculcate it.
And we can only develop from that particular part. So it is two-way
So forget about AI. Even very simple thing as video. So I think that attitude is very important.
Attitude and aptitude must be there, and zeal and workout must also be put into that. Then only that can go up. And this happens in every field across, not just embryology.
Yeah, I think that's a question said. Actually, that we say that only AI. There are so many things behind that. There are so much of work is done, machine learning, all these things. So I think it's a baby step what we are looking out, and probably the near future where we will feed more data. Any technology, the first we will resist, and probably we are looking something which is very unbiased, like we are looking something like that. So I think probably AI will play a very big role in probably not in embryo culture, but embryo selection. Because basically AI is an imaging technology. It is going to revolutionize the diagnostics era. That is going to be the big thing. And embryo selection, as we do now, we are doing through the morphology. Now we want to add through AI other parameters, biologically, physiologically, viability, omics, everything, so that we can get a better, wholesome selection. Thank you, everybody. Thank you.
So, for the message for the younger generation is that don't get panicky that AI is going to replace you. So, this 2 years which you are spending to go down the drain, no, don't do that. Ultimately, it is your knowledge, your dexterity, and your skill which is going to be implemented along with it. Who knows? Today, AI is at its peak. One fine day has certain problem and it may come crashing down as such. So manual interpretation is like CASA. I never trust CASA. I only trust CASA only in the morphological observation because the annotations of so many sperm heads come at a time together. Otherwise, the best is to trust your human eye. So as a panelist from Vijay sir, one message to be given for the embryologist.
Have a right attitude and right aptitude and the zeal to learn every day new things. That's the only thing.
Seconded by a healthy pay package.
Yeah, seconded by a good pay package. That's always there. And deserving candidates do get it. Absolutely nothing this one is that.
With all our patience.
Yes.
Sir, I want to ask one thing. And can you please throw some limelight on single step media? Sir was telling that 60 hours, every 60 hours we need to change the media. Is it really necessary? We were practicing and continuous culture system from day one to
You also have a timeline.
Yes, yes.
Yeah. Yes, there are a few things to look at. I would look at rather than anything else, change in osmolarity because it's such a small volume. There should not be osmolarity changing, which is kind of concentrating the salts, which is which actually prevents loss of formation. That's one reason, particularly because it is a dry incubator. As far as dry incubator, it's not a humidified incubator. So there will be evaporation until so many days. It is actually, I have practiced back in Singapore many years ago. But then, here we look at cost factors, changing the culture coin, one more, after a bit of it, how many patients can afford it. This is one of the reasons. And the other things, whatever you have said,
No, what is the recommendation? Like say you prepare the dish day before and you culture it post-mixing there, and then do we change dish on the day of culture?
No, we should change day 3. See, if we are doing ICSI, then it is on a day 3 because that's where the 60-hour timeline comes up. If I am doing IVF, then I do it at the same time of fertility. Post-denudation fertility.
So we need to check the embryo every day.
If you have a time lapse, you don't need to check it, but otherwise you will have to check it every day.
See, what we are doing is a limited time lapse, especially in IVF. We check on the foot, then we check it at 52 hours whether it has crossed the 4-cell block, turning into early ovulation, and if we want to transfer it at day 3 plus, a little later, or day 5. So, procedure on Monday morning, transfer maybe of a blastocyst Friday evening or Saturday morning. That's the parameter range.
We have one more, sorry. Thank you very much, everyone. It was a wonderful discussion. I'm sure, the whole day we can discuss, about these things. We'll mind them all.
Yes.
Okay. What we'll do is that, before we take on to the next panel, we have a small video to show you actually, the rapid vitrification glosses. We have both the oocyte as well as glosses, but we just want to show you. Anshul will, show that. In the meanwhile, for the next panel, please be ready. Tea, coffee will be served inside the room. Okay? Thank you. Thank you. Thank you. Moderators.
Swami.
Lily. A sheet is the projector attached. A sheet is not. Once again. 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 Thank you. आखिरी बार शून्य का आखिरी बार आपको
Good evening, everyone. I just want to talk briefly about a research study that we have been working on. So, it is about one protocol. We call it as Aspier protocol. It is nothing but a modified vitrification and warming protocol. So, just to give a little brief background, we all know that vitrification has been practiced from 20 years. And prior to that, for 20 years, slow freezing was practiced. But since the survival was not good with slow freezing, alternative methods were looked at. And that's how vitrification came into picture for human embryos. And of course, Register modified slow freezing media and we got higher success rates. Although vitrification is being practiced for so long now, but from the beginning only there are concerns regarding longer exposure, cryoprotectant toxicity and long-term consequences. Though we are looking at long-term follow-up, but how to reduce this toxicity, that should be of our major concern. So we have been doing this research for the past 2 years and we started our animal experiments for both oocytes as well as embryos. And we looked at different permutations and combinations in terms of time and the composition of vitrification solutions, trying to reduce both the time as well as the toxicity. So we have come up with a protocol. We call it as Aspier protocol. This protocol as a whole is a 1-minute protocol. So traditionally, we all know we had two droplets. One is the ES, the equilibration solution. The another droplet is the vitrification solution. But in 2014, Sir introduced a solution in between ES and VS to reduce the toxicity. And we have been working on refining this newly introduced solution. So I would like to show you all a video of mice blastocyst vitrification. So we put the blastocyst in V1 for 1 minute, and then we can see the changes. It shrinks. After that, when we put it in V2, again it re-expands. That is also for 1 minute. When it completely expands, that happens within 1 minute, we shift it to V3, and there we rinse it several times until it is completely shrink, and then we load it onto the cryo device that we have, and then we are vitrifying it. So the changes that we have seen here is that in the first drop itself, it completely shrank. In the second drop, it re-expanded, and third drop also until it shrinks, we are rinsing it. It might be something 25 to 30 times we are rinsing it. When we warm those oocytes, those blastocysts, which is also a modified protocol. So here we have only two solutions, W1 and W2, and we are exposing them in both the solutions for 1 minute. And you can see in both the solutions, it started expanding in W1 only, and by the time we shifted to W2, by the time of 1 minute, it was fully expanded. So, one of the reasons that we introduced this is the concern that longer exposure of gametes and embryos to cryoprotectants can end up clogging the aquaporins or osmotic channels. So here we dilute that concentration, and you can see 100% survival of the mice blastocyst. Similarly, we have done this protocol on oocytes as well, but considering the time constraint, I'm not playing those videos. So this is just preliminary information. We have already started working on human embryos that are not fit for patient use, and we have got encouraging results, and we're trying to work out a different protocol for human blastocysts. And so this is an ongoing research, and we are planning to come up with few publications regarding the same, and we'll be updating you as and when it's available. So I would like to conclude here. Thank you.
Thank you, Anshul. We are, going for the last panel discussion, which is on clinical and laboratory challenges in maintaining consistent pregnancies. I would like to call upon the moderators, Dr. Gopinathan and Dr. Sujata, to come on stage. And the panelists are Anshul, Dr. Kapshuram, Dr. Vijay Kumar, Dr. Jitendra Prajapati, Dr. Prakash, and Dr. Prajul. Over to you both.
ಲೈಟ್ ಬೇಡ ನನಗೆ ಕಾಣಿಸಲ್ಲ ಅವನು ವಿಸಿಬಲ್ ಐತಂತೆ ಅವನಿಗೇನು ವಿಸಿಬಲ್ ವಿಡಿಯೋ ಮಾಡೋದು ಒಂದಾರು ಆಫ್ ಮಾಡಿ ಅಂತ ಒಂದಾರು ಆಫ್ ಮಾಡಿ ಅಂತ ಏನಕ್ಕಂತೆ ಏನಿಲ್ಲ ಲೈಟ್ ಪ್ರಾಬ್ಲಮ್ ವೇಟ್
So the reason for having this panel is, we all know that IVF is a complex system. It it is influenced by several factors. Even the laboratory is influenced by more than 300 and odd factors. So what happens is it becomes very difficult to get consistent pregnancy rates. Okay, because there are labs which get 70% pregnancy rate in 1 month and the next month it will be a complete washout. So what do we do to have a consistent pregnancy rate? So that is the intention of having this panel. So this is one question that sir would like to ask the clinicians who are here.
How do you counsel a couple or a lady who comes with low AMH? Usually background of low AMH. Actually, I don't know whether how many people remember we started AMH estimation to decide the dose of stimulation. Remember that? See, now it is totally changed. Now it is a first, probably the first day investigation couple that is so important now. See, then, my question is, a patient, unmarried girl is going to get married, want to know her fertility status and all, because it's very common nowadays. She has got low AMH. Number two, the couple comes after 1 or 2 years for their first investigation. She has got a low AMH. A couple comes after 10 years. First time they, everything is normal, but only low AMH, around 1, I'm talking about around 1. Another couple comes with low AMH with endometriosis. All these questions, please, you answer. One, a girl comes with a low AMH.
Is it unmarried girl?
What do you tell? Come say that.
So you mean an unmarried girl coming with a low AMH?
Yeah, he is going to get married.
Going to get married. Okay. So first of all, I think a low AMH doesn't mean that she's not going to conceive naturally. So
No, I will tell that. What you will tell to the girl? You get married early, or you don't get married immediately, or you don't get pregnancy immediately. You enjoy your life and get married, maybe have a baby after 5 years.
Yeah, so
that's what I want to know.
Yeah, a lady with a low AMH, obviously we have to tell her that, for some reason, her egg reserve has come down earlier than expected. So her chance of, so she has to, we have to educate her that, there is a certain number of egg reserve in everybody, and it usually comes down after so many years, but in your case it has just come down so quickly. So she has to plan her pregnancy, she has to plan her life, in a better way. So she has to plan her conception earlier than later. So that education we have to give her. But that depends on her career and her this one. And if she's planning to put off her pregnancy bearing time, then probably we'll have to advise her to freeze her oocytes. So if she doesn't have any immediate plan to marry and have a baby, then we have to advise her social egg freezing.
My second question, that the couple comes after 10 years, everything is normal. AMH is one. Whether you go, they have not done much treatments. They come for, they have seen some 2-3 doctors, and they are not told anything. After they have done laparoscopy, everything is normal. Semen is normal. They are staying together, having normal sex together. Laparoscopy is normal. Then, what is your first line of treatment when AMH is low? After 10 years, everything normal. So far, she was treated as an unexplained infertility. Whether you will do IUI, or you do some induction of thing, or IVF.
10 years of marriage, so most probably she would have married at the age of early 20s or 25. So 10 years of marriage, definitely she would have crossed 30 years. So there are two clinical dilemmas, whether we have to advise the patient to go for IUI or IVF. So since our AMH is already low, so instead of using those eggs for the IUI, so we know that whatever the results is between 10 to 15% in the IUI, so we can give the option of IVF. So if she is approaching 35, so late 30s, we can give the both options. But so whatever the financial condition also matters. So but whenever the result comes, so definitely it is the IVF which we can advise.
I think we should not worry about their financial status. They have come to us to tell the what is the right treatment for them. Why should you worry about their financial status?
I think
they will make, let them make. Suppose you say, no, basically what does that mean? The AMH is low, most likely that AMH is responsible for that. Previously what we never used to do AMH, no. Then it was unexplained. Now we are really doing AMH, now you know this, it is not good. I think you should not delay them. They should get the best available treatment to everybody.
In that case,
right. And my third question, a patient comes with a low AMH, maybe 2 years only married. Whether you do, and with endometriosis, whether you do surgery or directly go for IVF.
So it depends on how big is the endometrium. So it depends on how severe the endometriosis is. Whether she has an endometrioma or whether it is just pelvic endometriosis. If she has a big endometrioma more than 4 centimeters, 5 centimeters, probably it makes sense to operate and then go for IVF immediately. But if the endometrioma is less than 3 centimeters, then no need for surgery. So we can go for IVF as soon as possible.
But this standard this thing is now, whatever may be your expertise, definitely your surgery is going to reduce further.
Exactly.
Do you believe in that? And if so, whether you will do surgery or not? That's my question.
So the main dictum in endometriosis is if a first surgery has to be the perfect surgery. If at all if you are going to operate, the first surgery has to be a complete surgery. So we have to avoid any repeat surgery on endometriosis. So
no, suppose you do surgery and the patient gets 0.5 after the surgery of some time. There is a possibility like that. So whether it is advisable and how do you see after some time there comes no your AMH is less, your surgery has further reduced my AMH. Then
the patient
severe endometriosis definitely no. Even small endometriosis is worth doing surgery when AMH is 1, something like 1. That's my question.
No, small endometrioma is not.
All people can answer these questions. No, anybody who want to tell, anybody can tell.
I mean, whatever evidence we have, less than 3 centimeters, 4 centimeter endometrioma, there is no need to operate. We can go ahead with the IVF straight, without doing any surgery. If it is bigger one, then they need.
No, my question is whether because you want to have a normal, try to have a normal conception by restoring the anatomy by your surgery. Now, that is whether to do that or not.
Sir, in this one, so I have one more. So endometriosis surgery is only indicated if it is obstructing the ovum pickup and you are going for the IVF. Suppose if the endometrium is very small, so AMH is really low, so we can directly start up with IVF and we can go for ovum pickup instead of advising for the surgery. So which can reduce our AMH level still. Only if it is obstructing the pickup of the oocytes, so then we may take a call for this one surgery.
Even that was the practice we did a long time. See, when there was an endometriotic cyst, which is larger, before surgery, we used to do surgery, reduce the size of the cyst, remove the obstruction and make the way clear for ovum pickup. Even I don't know, even that is accepted now, even with a large ovarian cyst, whether to do surgery in endometriosis before ART, to improve the chances of pickup.
In this patient, the question is how to get them pregnant. Now, getting them pregnant by doing a surgery with the possibility that there can be further reduction in your AMH and your further reduction in your IVF results after that. So, probably the first line of management, I would always suggest is to go directly for an IVF. Again, like I said, if they're not done in 2 years, they're not sure, the sexual frequency is not really. So probably when you counsel them, we can always give them an option if you want to try an IVF, because not that IUI is a treatment of endometriosis, but we are at least making sure that things are all happening correctly. Because like I said, guys, a lot of couples, actually what happens is that a proper induction with the time sexual intercourse does not happen in most of the normal scenarios. So if the patient is for an IVF, I would not want to do a surgery.
Particularly in this scenario, endometriosis with a low AMH. For example, if there is endometriosis that is a normal AMH, probably you have time in those people to either do surgery and wait for normal conception. But already with the low AMH, endometriosis, quality of the oocytes is going to be low. Then I don't think we have much time in those people.
I think you should don't spend time on surgery and all. Better to do when low AMH, you should not try. That's what my impression is. You can tell what is your impression about what is to be done. Better to go directly. Another very bad patient with very severe oligospermia coming to you with low AMH, what you should do?
And there's no confusion because there's the whole idea is that when there's already a female factor, male factor, female factor, both are there. So at this point of time, I think we should not now to improve the person's male, if at all you want to attempt to improve the person's male factor, we might have to give some medicines, you should give them time, you want to do whatever it is, people for them who do varicose. For all that we need to give the time. But unfortunately for the female partner, we don't only think that we don't have the time. So in this patient there's no confusion, directly go for it.
I think when there is an additional factor, basically in short I want to try to discuss when there is a low AMH, there is any additional factor, it is better not to delay time in such cases. Okay, next is.
I think we will give the clinicians a break and I don't want the embryologists to sleep. Okay, so see, to achieve consistent pregnancy rates, what do you think is the role of the environment? Does it matter? How much does it matter?
Yeah, lab environment, it plays a key role when we talk about consistent pregnancy. So one thing is controlling. We can only control when we are monitoring it on a daily basis. So be it lab VOC, temperature, humidity, that has to be monitored on a daily basis so that even if there is a slight variation, that can be addressed then and there.
So actually you mentioned about humidity. Now there are labs which will, we say that humidity should be maintained between 40 to 50, relative humidity percentage. In some places, the humidity is very high. Say it is 70%. Now, embryologists from there, they would say the reason for their decrease in pregnancy or decrease in blastulation rate is because of this increase in humidity. Does it have any scientific, correlation? What does increased humidity in the atmosphere actually impact on?
See, what happens, there is something known as, the performance of any equipment. So, since we are culturing the embryos, say for example, if we have a time lapse, so the optimum temperature for a time lapse to function is 24 degrees Celsius, okay? So, when the humidity increases, there will be moisture. Then time lapse won't be able to function. So, it will have an impact on the embryo culture growing there.
Do you agree with this, Dr. Vijay?
Higher RH basically increases condensations within the environment and the people working there will get disturbed by the high RH. And thereby the chain of events will stand. Condensation on a cold spot in a high RH environment will lead to rusting, contamination of certain things. It leads to a chain of events. So the ideal for relative humidity within an environment is roughly around about 55 to 60.
So how do you, suppose if you have 70%, what do you do to reduce?
Switch on an AC.
No, but then AC is already there.
No, HVAC systems we are talking about,
Yes.
it's not a dedicated AC or anything. You can make it. Or other way is to do dehumidifiers. There are suction mediated dehumidifiers available. So you keep only the suction unit in the laboratory and the dehumidification part outside. You have to have suction unit only in the laboratory, but dehumidification should occur somewhere outside at a distance. So that way. So if you have got an air circulation system, proper HVAC system in place, then this problem can be avoided better. But because HVAC system is going to have cost implications on it, one should be ready to have a dedicated HVAC system with ULPR, HEPA filters and VOC filters as an addition of this one to control the entire ambient environment within the IVF laboratory in a high cost.
So, but what happens when the humidity is very less? Say, for example, in
If the
places like
humidity is very less, you are not going to be affected. Because in the incubator, intra-incubator environment, you will have to keep it humidified. Or if you are using it as a dry incubator, then you have got to optimize your oil and the amount of oil what you layer and other things, which you know after certain titrations you will be able to arrive at a safe limit for you. So you should use it according to that particular protocol. Low humidity will not affect you.
But wouldn't it affect the operator? Won't it cause dry ice?
It does, but that is more acceptable than the high humidity.
So now, coming to Anchal's point there, unless you measure, you cannot control it.
Yes.
How do you measure? How frequently do you measure? And what is the recommended frequency?
Ideally, it has to be mentioned every day at a fixed point of time. And then nowadays, we have systems where we can remotely monitoring whether we are there or not, what is the temperature in my lab, even what is the voltage in my lab. So those things can be
just let's talk about the equipment which is needed for this daily monitoring. What all do we need?
For equipments, we religiously have to, measure the incubator temperature, CO2, and then their pH changes. Even for time lapse, benchtop and box type, for all the incubators, we need to have that. And additionally, we have to make sure that it is cleaned regularly. And not just auto start, it has to be.
No, let's talk about the air quality only there. Like we are just looking at the equipment which is needed. The reason I'm insisting on that is many times in many labs, almost like 70% of the labs, this kind of monitoring is outsourced. Meaning, like before every batch, or maybe once in 3 months, they just come with an equipment, an outsourced company would come, and then they would just measure all the parameters and go. Is that enough?
No, ma'am, it has to be done every day, and then any variation has to be addressed.
Okay, and then what are the factors or the processes which happen in an IVF lab which can impact on the air quality? Any one of you, personally.
See, the different things like what can happen, obviously, if you have a fridge inside your IVF lab, for example, to keep in the media. Now it all depends on whether you're using a commercially, like a regular fridge or fridge that are specifically refrigerators that are specifically made for contents. Now what it emits, it can emit VOCs and other products.
See, this is a very important take-home messages because I have seen labs where they store the media fridge inside the lab. They store liquid nitrogen tanks inside the lab, which is totally not accepted.
No, you're opening any new boxes, opening the boxes of dishes and things like that. Suddenly when you're opening the boxes of dishes, there can be sudden release of VOCs and things like that. See, another very important point I wanted to add in the previous one was that, see, the challenge with the monitoring all these things regularly, that even the monitoring device needs to be calibrated regularly.
Monitoring device also needs monitoring.
Monitoring device also needs monitoring. So that has to be calibrated regularly. Then only we will be able to monitor this correctly and accept the results that we are getting from it.
So there are a lot of things, and then please understand that human beings are the major source of contaminants. So the more people enter the lab, the more people walk in, that actually increases the contamination. There is a study which shows that a human being who just sits in the lab would generate so many particles. If the same person gets up and starts to walk, it generates more particles. If the person actually, does some frenzied activity, the particle number gets multiplied. So, we are the major source of contaminants. So, it is important that, we restrict ourselves in the lab. And after that, all the points they have said, like you have cardboard boxes, you have plastic sleeves in which your consumables come. They should not actually come inside the lab. And then your gas as such can actually release VOCs. All new, suppose if you buy a new incubator, that can release VOCs. So you have to keep the incubator outside, kind of off-gas it for a week or 10 days, then you bring the incubator inside.
So generally, that is also one point where we generally use a AHU system, air handling unit, to do the whole thing. That obviously takes care of the majority of the things. But what happens, it's always better to have another VOC device inside your lab, because every time you walk in, you are carrying along a lot of VOCs along with it. So that does not get fully filtered in this thing. Like everything that you're opening up inside the lab, all those things also are producing. So it's always better to have, if you're having a good AHU, it's always better to have an additional small, another meter inside the light. That's what we have been always doing.
Absolutely. So then there's another thing is measuring temperature. So we are so, obsessive about measuring the ICSI stage temperature, the laminar airflow temperature, but we really don't care about the ambient temperature. If you just walk into a lab, so many times I've felt that I'm really feeling cold. And you just look at the temperature, it would be 19 degrees Celsius. Now, can anyone from the panel say that how important is ambient temperature and how much should we maintain the cell?
It's of a very high importance. Ambient temperature should be assistive. Whatever incubators or heating instruments we use, they do not have a cooling possibility. So you should not have there should be a minimum 10 degree below. The ambient temperature should be bare minimum 10 degree below the set temperatures of your heating incubation system. That puts my maximum temperature to be at, room temperature to be at 27. But at 27, some people might feel uncomfortable. So the ideal ambient temperature is between 22 to 26. Whichever is, most of the laboratory working people can be this one. So like averaging and mean it out to around about 24, 25 is the ideal ambient temperature for the consistent performance of your incubator as well as the people working in the environment.
So now I just hand over to sir.
About the different type of protocols. When we started in 96, everybody was getting long protocol, and some people that time also we had short protocol. We started with a small dose of leuprolide with the HMG or FSH from the second day, give it some days. Then, because the main problem that we faced was the hyperstimulation syndrome. So everybody everybody wanted to shorten the cycle. So then came the antagonist. And everybody claimed that antagonist protocol do not produce hyperstimulation. And everybody shifted to antagonistic protocol. After some time, many people understood antagonist also can produce hyperstimulation. By that time, vitrification, till that time, the slow freezing was the rule and it was not at all successful. Not even 10% to 15% extra. Dr. Suresh who claimed a little extra. None of these cryopreservation techniques were slow, was not at all doing good work. We had to spend a lot of money. Then came the vitrification. When vitrification became very popular, all started doing vitrification on the embryos to avoid this hyperstimulation. Also, leuprolide trigger came because of that. Because we get a lot of embryos, we are sure that all the embryos will get it after cryopreservation. We can totally avoid hyperstimulation. Then again, see why do you want to spend? Anyway, vitrification is we are doing. Why you want to do all these antagonistic? Then came this estrogen primed and progesterone primed protocols where you need not spend on antagonistic protocol. You just start the stimulation, give the trigger. My question is, we got a lot of selection in this group of patients. And see what is your ideal stimulation protocol and how do you select the protocol? That's my question. You got long protocol, antagonistic protocol with agonist trigger, estrogen primed, progesterone primed. You select one or two indications, you tell me what is your, why do you select and what is your protocol?
So first of all, the most of the IO centers now they are into antagonist protocol. So the more or less comparability, compared to agonist protocol, more or less it is the same. But when it comes to the poor responders, so nowadays again the agonist protocol is coming a long way as compared to the antagonist protocol in the poor responder. When the patient is normal responder, the PCOD, definitely will go for antagonist protocol. So if the patient is with a poor ovarian reserve, so it all depends whether to go for antagonist. First preference will be antagonist protocol. So if it is not working out, then we may have to go for long agonist protocol.
You don't prefer estrogen priming, progesterone?
Sir, estrogen priming again, it adds upon the cost for the patients. So estrogen priming as per the guidelines, as per the evidence, so there is no extra benefit by adding the estrogen. So now one more thing which is coming is progesterone primed ovarian stimulation, PPOS stimulation. So it says that it prevents the LSR. But in my routine practice, so most of the centers are used with the antagonist protocol. So we would like to continue with the antagonist protocol at the moment. So but in the future, so sir.
So in short, you feel in most of the cases, long protocol is good enough, except when you are bothered about hyperstimulation. Am I correct?
Yes, sir.
What about others?
No, I think you meant to say most of the times antagonist protocol is fine.
Is it like that?
Yeah. No, most of the times, most of the centers we are following antagonist protocol.
No, see, I'm talking about, what is that? See, except when you are expecting hyperstimulation. Other than that, which protocol is?
So, but still, the antagonist protocol is still.
No, you don't feel like you should do agonist protocol?
Agonist protocol again, it's a long protocol. So, it all one is the duration of stimulation, the second is the.
What is 1 week extra?
So, so patient has to take 1 more week extra injections as compared to the antagonist protocol.
I think the main is the outcome, whether you use an antagonist protocol or a long protocol. So the live birth rate is not significantly different.
But that's
if you look at the antagonist and the long echo, especially in the normal responders, I don't think there is a significant difference. Maybe in the poor responders, Poseidon 3 and 4, there it makes a difference. Having a long agonist protocol or a short play protocol, it may give some better oocytes. But other than that, the normal responders and the hyper responders, the evidence says the outcome is the same.
If I can add,
but my doubt is, long protocol, why there is hyperstimulation?
So because of the trigger which we use, the HCG.
No, because you have more X. Is it not? That everybody agrees, no? Long protocol, you have more number of X. When other than antagonist, what is, except when you are not having hyperstimulation, why don't you use that? That's my question.
Sir, actually, the OHSS basically in the agonist protocol, the duration of action of HCG is 7 days. So whereas in the antagonist protocol, so the agonist, the duration, so the surge comes for just 24 hours. So it goes off, and whatever this was accretion, Vajan factor, the duration of that trigger is just for 24 hours. Whereas in the agonist protocol, the duration of action of HCG is 7 days. So even after the oocyte retrieval, the chance of OHSS is more in agonist.
What about that?
I think with regards to protocol, I think what we should always understand is, I think everybody is customized and everybody has their own favorite protocol, because that is their favorite protocol, because they are getting the best outcome in that. If you're not getting the best outcome in that, you will not be their first favorite protocol. Obviously, I think what basically is the debate, because we always talk about agonist, antagonist, is probably the most commonest thing that we always debate about. But I think what really makes difference is just not about that protocol. I think what I've realized is it's a combination of multiple factors. Say for example, an HMG stimulation with a long protocol and an HCG trigger gives we have been getting excellent results with it. At the same time, the combination would be an antac protocol, recombinant stimulation and an agonist trigger. A lot of people are getting excellent results from that. So a lot of people continue to follow that. But at the same time, when I'm trying to use recombinant FSH in a long protocol, I think like what Gupsa was saying, the last few years HMG was not very great. Post-COVID, I think because of the Ukraine war and all those things, there has been an actual issue with the raw materials that are available for HMG. So the quality of HMG was not good, and then it suddenly changed into recombinants. The same long protocol, what we were getting no hyperstimulations. Suddenly we are seeing a lot of hyperstimulations with recombinants. So I think it is just, when you talk about protocol, it's just not about one drug that we are talking about. We are talking about a combination of multiple factors, and then ultimately, so I think everybody has their own favorite protocol. So whenever a patient comes to us,
See, unless they've already done your own protocol before, probably you want to try a different protocol. Like sir was saying in the morning, like you would like to see a discharge summary. If they have already done a ANDAC protocol earlier, I would like to do an agonist protocol. Already done an agonist protocol, this time I would like to do an ANDAC protocol. But if the patient is coming for to me the first time, I will always prefer to do the protocol that has given me the best result. And if that fails, probably next time I will change, because every patient is different. We are trying to utilize that protocol that is going to be the most favorite of us to suit that patient, but it will not.
A little off the topic which I am going, because I am not a clinician, so I will not talk about the stimulation protocols. Rather, I would say from the laboratory perspective, how the stimulation protocols have affected me. Because most of the times I am involved only into the ICSI cases, so I get to see the oocyte firsthand when I am injecting. When people were using exclusive lung protocols, the smooth endoplasmic reticular clusters are the discs, what we call it as, and the granularity, especially the centralized granularity, localized granularity. These two abnormalities are the dysmorphisms in the oocyte, which alpha consensus and most of the consensus say that if you see SCRD, do not inject that oocyte. They straight away reject that. That numbers in antagonist protocol can come up to almost 50%. In agonist, it is not at all seen. Probably has to do with little longer duration of stimulation. In antagonist protocol, I'm sorry to say this, but sometimes I have seen that people give stimulation only for 7 days, post it for 2 days, all these things. And we know that, and most of the people, you see the history sheets many a times, because when I started noticing this repeatedly in antagonist, whether it is estrogen prime, progesterone prime, whatever they have been trying and anything, my picture of oocyte in the lab was not changing. I used to have a larger perivitaline space, dysmorphic sizes of the polar body started increasing. They do not affect me per se. What affects this one, as per the consensus guidelines, is the granularity, centralized granularity and smooth endoplasmic reticular clusters. These two are indicative of cytoplasmic immaturity. Nuclear maturity has occurred because of our trigger and other things, but cytoplasmically that oocytes are still immature. So there is a disparity of nuclear and cytoplasmic maturity. Cytoplasmic immature oocytes you should not inject. That's what is the consensus. Now when I started pulling out only the case sheets of the stimulation and other things, most of these people were into 7 to 9 day stimulation. Which, as a clinician, they were saying that, oh, it is excellent, I had 12 oocyte, 12 follicles on the follicle and very good triple line endometrium. All the clinical parameters of the sonography was fantastically monitored, and they said, and when we aspirated it out, we got 11 out of 12 or 12 out of 12 oocytes all the time. And in the lab, I am saying that 11 or 10 M2s are there. So, if you look at the KPI point of view, they are fine. But if I look at the morphological point of view, 6 of my oocytes are cytoplasmically immature, but nuclear mature. So, I am having only 6 mature oocytes out of the 12, that is 50%. This reduction actually, pregnancy rates have been consistent between 35 to 42%. I will not say that I am having a very out of the way. Between these two, yes, they are also less. Because 50% of my pool itself is not out of question. They are out of the race. So this problem, we never used to see this much amount of disparity among a cohort of 8 to 10 oocytes, what we used to get. In a stimulated cycle, in agonist, the cohort used to always go together there. In antagonist, it doesn't go.
See, basically my approach, we have a center, we have all the 3 centers. We are, most of the cases we are doing down protocol. And the basic concept about that is now, that protocol gives the maximum progress. The only contraindication or the problem is hyperstimulation. My hyperstimulation I have managed till now 26 years. I had no problem. Severe, yes, we had problem, but we have managed. But when you comparing, see, you just think, no, when you are doing a patient with a lesser ovarian reserve, what is the best protocol? Then it should be long protocol. I don't believe that antagonistic protocol will do better. That is my idea. That's what you need not agree. Everybody has their own opinion. You can But whatever I have come in my mind, I told you that's all.
So, see, there was a paper which was published in Fertility and Sterility 10 years back, and there was an update also on that. They looked at consistently well-performing centers in US, and they looked at the parameters which they are following, which is not followed by the others. Okay, these are centers which have a very consistent pregnancy rate. And one of the parameters which was mentioned there was selective use of ICSI. Okay, now I want to ask my panelists, what do you think about it? Should it be ICSI for all, or should it be IVF, or what is your opinion?
Although we are doing ICSI for all everywhere, but I personally feel ICSI should be only done when it is indicated. ICSI should only be done for male factor cases. Otherwise, if the semen parameters are normal, we should do IVF. That I feel.
If you have more number of eggs, why you try ICSI for half and ICSI for?
We have not tried like that.
And you know the difference.
See, like I said, in our scenario, probably having a fertilization media in our Indian context is quite challenging. So obviously, we all today know that IVF being a more natural selection process, going a more natural process. So if you have more number of eggs, you always try to do half of each. And if you are getting good blastocyst or good quality embryoes in either of them, we prefer to use the IVF first, then the ICSI. But otherwise, when you have less number of eggs and these doubtful ones, wherein we are not sure, okay, there is no specific male factor, but then again, oocyte, because what like I think today morning also we were discussing, today we are ending up seeing a lot of these bad patients. See, all young patients coming with low AMH, thick zona, average oocyte quality. Those group of patients, we are little worried whether to leave them off with IVF alone.
Okay. So, but I think what the evidence now is, IVF actually works better in these poor prognosis cases where Dr. Vijay was mentioning about the cytoplasmic maturity. So the moment you do ICSI on an cytoplasmically immature egg, you are just releasing, lysing the cytoplasm and they are degenerating immediately. So, but at least if you do IVF insemination, the chances are that, maturation also happens and in the process, fertilization also happens. What is your...
I do not diverge away from that particular statement. It is true, IVF works fine, but in the last 14 years of my practice, initially I was doing exclusive IVF only, and in the last 14 years I am called only for performing ICSI. So I do not have a chance of doing IVF there. So my statement of anything would be biased, and I say that for me, even when I was teaching to the people and other things also, I was telling the same. There is only the way the sperm enters into the oocyte is the only difference thing between IVF and ICSI, nothing more. And because it is me who is selecting the sperm, if something goes wrong in ICSI, then I am responsible, it is not the galaxy. That is my first statement. Operator responsibility is there in ICSI. Operator responsibility is little less when it comes to IVF. That's number one point. Number 2 point, most of the people who say that they are doing IVF do not know how to do IVF. They do not know what is the critical sperm concentration to be added. They do not know whether to go for a short co-incubation or a long co-incubation.
So for the
how to
benefit of
decide.
people who are here, why don't you just tell us what is the ideal sperm concentration?
Ideal sperm concentration is roughly the maximum sperm which you should be putting around the oocyte is 3000. I am giving you exact numbers. Any per oocyte, 3000 per oocyte. And like I said, I have never in my life I have practiced root culturing. So you cannot ask me how many oocytes per OCCs per droplet. Mine is always 1 OCC per droplet. I use a 60 millimeter dish, 12 droplets of 30 microliters, 1 oocyte in each droplet, and 6 ml of oil, 8 ml of oil layered on top of it. And that's how I used to use it. And 3000 sperms. You have to titrate it to 1 million per ml and calculate using calculators or anything you can easily calculate. 3000 absolute motile sperm should be there next to the oocyte, and that is maximum I am talking about. This is not minimum. And if you add anything more than that, then you are going to have overcrowding and other things. So
What is it? Is it short insemination?
Mine is always a long co-incubation. I have never done a short co-incubation, so I always do long co-incubation. So usually at around about 6 in the evening, I inseminate. Next day 9 in the morning, I deglue.
Okay, so one of the major, concerns while doing IVF is total fertilization failure. People are scared about that.
Out of the 16 years of practice, I might have had a finger countable number of total fertilization failures. No. When I was doing exclusive IVF also. So that is, yes, that chance exists. But that is not that much hype like what we have to think about it.
So what do you think are the factors which can help us in predicting and preventing total fertilization?
Predicting a total fertilization failure is impossible. You can prevent it. Dr. Katera's paper is there. So that's where short co-incubation and quick denudation comes into picture. That's number one. Exclusion of the second polar body is one indicator. And in case of a total fertilization failure also, if you carefully look at an IVF fertilized egg, you will see lot of sperm attachments, and at various levels in the zona, you can see the sperm penetration. They will be attached all the time. If that attachment is zero, even if you rotate the oocyte and if that attachment is zero, then there might be certain problem with the sperm and the zona pellucida binding. If that itself is not occurring, then no matter how much ever you try and do, you might not get a response. So there you might have to go for a rescue ICSI. If you are following Dr. Katera's showing short incubation with second polar body exclusion time observation, you go for rescue ICSI right at that particular moment. In case if you do not find any sperm attachment at the end of this one by any chance, not even a single sperm is attached to the zona, then you perform a rescue ICSI right away at that moment. These are the two parameters which you have got to get it across. But out of, for about 18 years I did exclusive IVF, and I can still say that 5 or 7 times only I have had a total fertilization.
So one of the
rather in IVF I have had multiple pronuclei as a problem to me at times, and that used to happen with post-luteal.
But how you address this few cases of fertilization failure?
There I did rescue ICSI and left it to God, that's it.
But what is, since you are handling a pan-India center, what is in your experience where people have done only IVF and what is the fertilization?
So unfortunately ours is like 100% ICSI, okay. But then of late we have been having issues with degeneration rates, especially in this poor ovarian reserve cases where we get only few eggs, less than 5 eggs, and then like half of it goes on this thing. So we actually have started a prospective study where in these cases we just, if the sperm is good, we are doing only IVF. I think maybe in the next meeting also I will give you data, like it's going to be a prospective study.
Sperm is good, I think we can do this instead of damaging the water.
So, Dr. Katera, you tell us when to stop.
Here it is. Here it is.
The question is, can we predict fertilization failure, total fertilization failure? I think to a large extent, yes. See, the problem is, like if he is, saying, very few I seen, but if you look into the literature, it varies anywhere from 5 to 15%. That depends on the individual, embryologist. Where to put the cutoff mark actually. What is male factor, what is non-male factor? Now, if you are, everything looks fine actually. When you do a semen analysis, there are two things which predicts. One is, progression of the sperm. If the sperm progression is, majority of it slow progressive, then fast progressive. It's a predictive indicator actually. In combination with the morphology, Kruger-Strick morphology, it predicts in 90% of the cases. The second thing is actually, say, it says, there is a possibility, you go ahead and inseminate, short co-incubation, and then you see actually, so what happens, the sperm has to penetrate to the cumulus corona actually, it has to release this enzyme, hyaluronidase, it has to break the hyaluronic acid in the cumulus. Now if it doesn't break, it doesn't reach the zona at all, when you do a conventional IVF, you don't see any sperms sticking, which means the sperm didn't make it up to the zona. Now if it crosses here, it has hyaline days, but reaches the zona, it is sticking around there, but it has not gone inside. Probably it lacks the acrosine enzyme actually. Now even if it manages to get in there, no fertilization, it's not able to activate the oocyte actually. So we can actually, like up to the short co-incubation, if you see what happens is short co-incubation, we don't measure the concentration, because if you expose for 2 hours and then denude it, and you don't see any sperm sticking around, which is a concern actually. It can generate ROS and all that stuff. Now when you do that, if easily actually, you can separate the oocyte from the cumulus if it has entered the egg actually. Now if it is not still separated from the cumulus, which means sperm has not been able to pass through the cumulus. That's an indication actually. So you can do an early rescue XC actually. So to a large extent, we can do that. Even the age-old test that we do actually, sperm survival test. If it doesn't survive, there are samples actually when you do sperm survival post swimmer, and if the sperms don't survive beyond 24 hours, clear case, you cannot do conventional IVF. You have to do XC actually. Even in these cases, people do the repeated IUI actually. If you do this test, you don't have to do repeated IUI. You straight away go for XC actually. So there are ways and means actually to prevent fertilization. Now with the time lapse, when you have this short co-incubation, if you monitor embryos, so you see release of the second polar body, which you mentioned actually. You can still like in these cases do a rescue XC actually. So I mean this is what we feel actually.
So the excellent points here Dr. Katera has mentioned, but one of the very basic things here is an embryologist should know how to evaluate a sperm. What happens is, and I'm sorry to say that.
Can we ask?
One second.
Can we ask the gag people only this question? How do they evolve the speed of the sperm?
I just want to convey a very important message here, and especially people who are finishing clinical embryology course. They just are there in the andrology laboratory only for a very short period of time. After that, they feel that it is much below their distinct status to do anything. Sperm preparation, semen analysis, because they only want to concentrate on ICSI and vitrification and embryo transfer. But then, a best embryologist is a person who's not the one who is doing ICSI well, that is an ICSI technician. A best embryologist is somebody who can look at a sperm and what all Dr. Katera said now. You look at the acrosome, you look at the movement, you look at the progressive movement, you look at the morphology. Somebody who has a complete grip of the sperm. So that makes a good embryologist, and only when you are a good embryologist, you can actually, predict. Otherwise, you will just function as a technician there.
Now reverse question from panelists to the audience. How do you assess the speed of a sperm in the absence of CASA? You don't have a CASA system, but yet you can say what is the speed of the sperm. How can you assess the speed of the sperm? At what rate it is accelerating? How do you measure it? I am asking you that. 25 microns per second is the rapid, I know. How do you measure it? Not subjectively, objectively. Yes, under a compound microscope, how?
Sir,
Yeah, give the mic to her, please.
Hello everyone, I am Richa. Sir, answer to your question is that we will look into the grid and
Grid of what?
Grid of macular chamber.
Okay.
And with the reference of that, we can identify whether it's a rapid progressive, like how quickly they are moving from one.
My question is that same. How quick? How do you measure it? Quick is a subjective term. How quick is still subjective?
Sir, if like we have
You are partly to that answer.
If we have 1 second,
Yes.
And we will, like, if we can calculate 1/4 of a second, and if a sperm is moving
Can you
1/4 of
calculate 1/4 of a second?
Sir, that's an instinct.
It's like, you have to focus.
See, simple. You are halfway through, but you are not putting it in right perspective. That's what I'll help
Well,
you
we are
out.
not
I'll
able
help
to
you out. I'll help
put
you
it
out.
into
What's the size of a
sentence.
macular grid?
Sorry, sir.
What's the size of a macular grid?
Sir, 10 micron is the
10 micron is the depth, height. What's the length and breadth of macular grid?
0.1 into 0.1.
0.1 into 0.1, that is 100 microns.
Yes, sir.
The entire is 1 micron by 1 micron, so each square is 100 micron square. Since it is a square, anyway, whether it is diagonal or vertical or horizontal, it is going to be 100 micron. In your mind, you start counting 1001, 1002, 1003, 1004. You can keep your stopwatch and you can check it up. When you say 1001, you will take only 1 second for mentioning. When you start counting from 1000. So in your mind, you start counting 1001, 1002, 1003, 1004, and you will see one sperm crossing whether diagonally or horizontally or vertically from one end of the square to the other end of the square. That is traveling at 25 microns per second.
That's a unique technique.
And it goes for 1006, 1005, 6, 7, 8. One sperm crosses, that is traveling at 15 microns per second. And it is not at all crossing even after 1010. That means it is a sluggish sperm. So you obviously can count what is the speed of the sperm. Then, in macular, if you carefully look at the macular's literature, nowhere it says that you have got to, of course they have mentioned it, in a horizontal grid of 10 or in a vertical grid of 10, but if you work out the mathematics of it, the mathematical calculation, you have to count sperms which are presenting 10 squares. So what you have got to do is count only one square at a time. One square top left corner. Then go diagonally 10 squares opposite top right corner. You can make 10 columns with respect to rapid, moderate, sluggish, twitching, non-motile. And when you see the first square, what you will never be able to miss in the first installment is non-motile sperm. So there are 2 in that square, so you mentioned 2. And there are 2 which are spot twitching there only, so you can mention that 2. Then you can count this 1001, this one. 3 sperms cross, so rapid is 3. 2 sperms cross at 1008, that is moderate. And 1 sperm is not at all crossing, that is sluggish. So 1 square is done, diagonally opposite 10 squares. If your top left, if you have taken, then bottom right. Then diagonally opposite here. Come back to this left side, the top left. Then you go for top right. Like that, 10 random squares you take it and individually mention. Total of these 10 squares will be your rapid, moderate and everything as per millions per ml. And total of the columns and total of the rows equivalent will be the entire sperm population, that is your concept. For your statistical clarity, repeat 3 times that analysis and take the average of it. You will never go wrong in your count and motility.
You have learned something new now. Let us just move on to the next question. So, for consistent pregnancies, incubators, they do play a very important role. I want the panelists to tell your experience. How do you optimize your incubator performance?
So, for incubator, the temperature, the CO2 and the humidity, the water level, it has to be checked every day. Not the water level every day, but the CO2 and the temperature. And we have to make sure that it is cleaned regularly. When I say cleaning of the incubator, if we talk about the box type, there are 2 types, auto start and controcon. Auto start has to be done once in every 2 weeks, that's what we do. And controcon once in 3 months, and after controcon, it has to be calibrated by the engineer itself.
So, but this is for the box type of incubators. Yes. Like majority of them, they do not use box type of incubators for culture. So, most of your culture is done on a bench incubator. How would you optimize it?
Even for a bench type incubator, we have to check the temperature every day.
So, what is your idea about temperature mapping? How do you check the temperature? Do you check at one particular place every time, or you just check it at different places?
For different chambers, we check it, and then we do it every day. So, for both bench type and time lapse as well. So, yeah, this is what we do. And in addition to that, for the bench-top incubators, we have to maintain an optimal water level also for that to function properly. So that also has to be done as far as the maintenance of the incubator is concerned.
So, Dr. Parsu, what is your thing about the ideal? Yeah?
I'm not the right person to answer that yet.
No, like you are the right person because how many incubators should we have? Because you run a hospital. So, for suppose if you are doing 30 pickups in a month, and then if you are doing regular pickups, how many? Is it enough that you just have a single bench incubator?
I think we should always understand why we are getting the incubator. So whenever one of our fellows or somebody asks me, I always tell them to take 2 box incubators. Because box there is a replacement, because any issue that happens to the box, there is always an alternative for box. What we can do in a bench top, we can do in a box. But what we can do in a box, we cannot do it in a bench top. So at least 2 box incubators and 1 bench top. If you have the money, 1 bench top incubator would be the first to start with. So whenever, at least this will be the minimum to start off with. But we can still go ahead with say 2 box incubators. But at least we should always have 1 backup.
What about you?
I usually say that smaller incubators are the better. Even I am a proponent of the box incubators. So smaller incubators are better. Say maybe around about 50 to 70 liters. To start with, you should have bare minimum 2 because your number of cases in the initial days might not be there. And 1 small incubator can only accommodate maximum 4 patients at a time. That's what is my personal assessment. So the moment you have more number of cases going on in multiples of 4, you start adding one incubator into this one. Because even if you take a benchtop incubator, the temperature replenishment would be much faster, agreed, but carbon dioxide equilibration is almost same in box and benchtop. There is no difference among it.
So our experience is slightly different. Like we do all our cultures in benchtop incubators. So when a new lab is set up, what we usually give them is 2 benchtop incubators and 1 box type of incubator. That is what we usually give them. And after every, when they cross 40 pickups, we add 1 incubator because what happens is, it is not only the pickups but the FETs will also increase. So we actually give them additional incubators. So we have a matrix. But here, what we have to think is, we do not do batches. It is every day we have pickups. So that means our incubators are working throughout. But if you are having batch, and I think you need to have more incubators, the reason being you will be opening it multiple times, and that even if it is a box or bench type of incubator, it will still affect your results if you open it multiple times. So anybody who is running a batch definitely should have ample incubators. And I agree with what Dr. Vijay said, 4 patients per incubator. That is what we do in all our wing for, each chamber we just keep only 2 patients. So that means in a wing we can keep maximum of 4 patients. But we also have large case systems where in 1 chamber we keep only 1 patient. So 10 chambers means we keep only 10 patients there. So
the new case system also has an incubation chamber. One of the reasons why we always go back to your box incubators to actually have an incubation for keeping the medias and things like that. So I think the new case system has got a separate space.
No, G185 had it from the beginning.
I think only G185.
G185 and
see, the recommendation is
G185 did not have. G210 has.
See, for equilibration, initially what we used to do was, we used to equilibrate our media in the box and then we transfer it to the benchtop. But then the recommendation now from those companies is, if you are equilibrating your media at less oxygen, it is better because oxygen, movement is much slower than carbon dioxide movement. So, like they say, you can equilibrate it in low oxygen. So, what we do is, in a case system single chamber, we will keep the patient's dish for equilibration and then use the same chamber for culture. So, that's the reason why we can't accommodate 2 patients there. So, I think the next one is, again, consistent pregnancies. Is it necessary that you have to do blastocyst transfer, or even with day 3 transfers do you get
it's almost the same. In percentage base, the difference is in the range of 5 to 3%. So it doesn't matter. It's a collective decision between the clinician and the embryologist, depending upon the good number of day 3 embryos what we have got and the endometrial preparations there and the support this one and the previous history, whatever the clinician thinks, collective decision. But as far as I have seen, day 3 and day 5 do not differ much after 32. Before 32 it might differ, but after 32 it has absolutely no difference.
So have you compared apple to apple, like age
Yes.
And you said your pregnancy rate is between 30 to 40%.
35 to 42%.
Dr. Prakash, do you want to comment on this?
We have been doing, most of our transfers have been blastocyst transfers for the last 2 years. I can talk about my statistics for the last 2 years. Before that, I wasn't working in India. So, our pregnancy, day 5, we haven't compared the day 3 and day 5 because the numbers are not same. The day 3 are quite less. So with the day 5, I would say we are getting good results. Our pregnancy rates are around 60 to 70%. It includes some of the biochemical pregnancies as well, I should say. So I think when we are selecting day 3 versus day 5, a lot of factors are there. For example, if somebody had a day 3 transfer previously, in previous failed cycles, and it was a day 3 transfer, I think probably it makes sense in that scenario to use a blastocyst transfer.
I completely agree with that. I said that it is a collective decision.
Yeah.
It is not my own decision.
Yeah, exactly.
Collective decision, both clinician and his inferences of the case, as well as the laboratory where I have only 2 good grade, you can say a B grade day 3 embryos. If I continue to blastocyst, probably without even transfer, I can say that I might not have a blastocyst to transfer. So whether to go with that or to this one. So it's a collective decision. And whenever we have done, even in that worst, not so favorable cases, I am talking only about that. When I take it and when I set it across, and all day 3 and day 5 and other thing, the pregnancy rates after 32 hasn't been greatly different between day 3 and day 5. Across parameters I am talking. Below 32, as such, I won't be called for certain cases where I will be exposed to below 32 patients, so I can't confidently speak. That's why I say I don't know the stats for that.
I think nowadays it is difficult to put a blanket statement like that because most of the patients, what we are seeing is, for example, if you have a lady who is 37 years, and if you are planning to do a PGT and then transfer her, because the aneuploidy rate could be quite high in those patients. We can't say that we transfer a day 3 embryos. In those patients, we have to do a day 5 and then do a biopsy and then take it.
Biopsy, freeze it,
yeah,
and then after that comes
so,
up, can't transfer. That's all.
So it cannot be a very blanket statement that I will do only day 3 and I will not do day 5. I think it has to be patient.
I just see. I think without any doubt, see, when I say there is an equal pregnancy rate between day 3 and day 5, it is not one day 3 embryo versus one blastocyst. Okay. When we talk about day 3 embryos, we are always talking about transferring multiple embryos. Okay. So, but then when you are transferring 2 to 3 embryos of day 3, probably will give you an equal result as a blastocyst. Implantation rate per embryo will be lesser in a day 3, no doubt about it. But again, one of the biggest challenges I think we've always, I think me and Dr. Sujata had a debate also, I think a few years back on this. The biggest challenge with consistent day 5 is, again, you need to have a good benchtop incubator. You need a low oxygen concentration culture to have benchtop. Now the benchtop incubators that have our incubators are different. There are some incubators that require pre-mixed gases. There are incubators that require regular gases. The ones that are having regular gases have a mixing system, so that is okay. But then the incubators that requires a pre-mixed gas, again getting good quality pre-mixed gas is one of the biggest challenges. So for example, being in the periphery, smaller places, one of the biggest challenges that we feel is the consistency of our day 5, because we are not sure of the quality of the day 5, the premixed gas is there. Hence, not because day 5 is bad, but because we are not sure. But at the same time, when you're doing a day 3, we are still getting away with a box and a basic benchtop incubator. So I think it all depends on what is available to you and how you utilize what is available to you to your maximum. So I think definitely, anyway, down the lane, day 5 is obviously one of the most per embryo. Per embryo, if you look at it, actually, Gopi sir is giving a talk next month, actually on day 3 fresh embryo transfers. So actually, we pulled out the data of all fresh day 3 embryo transfers, and fresh day 3 embryo transfers, we are getting a pregnancy rate of around 48-50%. Okay, so I would say it is inferior, but I would say that yes, my implantation rate, and I wouldn't say many of them are twins or triplets or the percentage is quite less. But obviously, the implantation rate per embryo probably might be lesser than day 3. There's no doubt.
Also, I would like to add one thing. For day 3 embryos, if you have suppose say 2 or 3 embryos, they might not become a blastocyst in vitro, but if you transfer it in vivo, they can take off. So that can be one upper hand.
Excellent. So this is the last question. So what does the panel think? Is education or experience, skill of embryologist important? Who is an ideal embryologist? Because there are a lot of students, because some of them we had even asked, what is that you look for when we apply for a job? So what do you think?
All three are important.
No, but then if the person cannot be a combination of all three.
See, basically, education and skill and experience after working, it comes up. And education is a continuous experiment. So the person has to be learning on a day-to-day basis. He has to keep on educating himself and updating himself. Experience will automatically carry on with years and years of this one. Skill, you have to understand that at the peak of the youth, you will be having higher energy, but lower onto the this one, and but your psychomotor skills will be much better. But as the age progresses, psychomotor this one takes back. Your experience covers for certain of your skills. So you will have to be try and master all three.
This actually is a question for the clinicians.
Yes.
So suppose if I gave Dr. Prakash an embryologist who is just passed out and has a wealth of knowledge in embryology, and also like we have trained and validated them, so their EC skills are exemplary. But would you still ask us that the person does not have experience, so I want an experienced embryologist? Would you ask? No, because the reason I'm asking this is, this is something which I face on a day-to-day basis, okay? Like we get students, we actually train them for 6 months in our training academy. You people are already trained. And then we fine-tune your skills in our training academy. Then we put you along with seniors in the labs. And then when the seniors tell, okay, like this is my KPI, this is the trainee's KPI, and that is the time we think that, okay, this person is good enough to handle cases independently, and then we transfer them to a center where, like to give them an opportunity to handle labs independently. And that is when the clinician tells me, no, I don't want this person, I want an experienced embryologist. No, I just want to understand the psychology of this.
So you need to, everybody has their own stress, levels. For example, we have a stress of, kind of giving the results, the stress of results, like the stress of outcome is there. So probably if we know what kind of validation process they undergo, and their the skills have been assessed in a very structured manner, maybe that will give us more reassurance to accept those new candidates to take live, clinical scenarios. Probably that is one of the things. But as a clinician, always there is a hesitation. So when we are taking a new person into live cases, so the information about their training process probably will help us to accept more easily.
So Dr. Prakash is actually with us, and then he is one of the team clinicians to work with. I'm just simply asking because he is the representative of clinicians here. But
can I add something here actually?
Please.
Okay, I think see, there are people who don't take risks. I am someone who take risk actually, very calculated risk. If you don't give opportunity, when will they get experience? See, it is like, if he is validated, if he is skilled, you should give an opportunity. Just to give an example.
It's like a saying.
My embryologist. I gave her actually, I took the risk actually to give her biopsy. She has turned out to be one of the best biopsies. The first biopsy itself, she got a pregnancy. So if you don't have confidence, then it's like taking a bit of a risk actually. Otherwise, they will remain in the embryology lab forever actually.
And one more thing, what I tell clinicians is that, see, how do you calculate experience? A person who is working in a center doing just say 10 pickups in a month. Whereas you have a trainee or an associate embryologist who has worked in a lab which does 90 to 120 pickups in a month. Now, who is more experienced? So the experience is what? It's not the number of years you put in. It is the number of cases you handle. So, I always tell the clinicians you have to look at that. And then, it is also very important that, and Dr. Prakash very rightly said, structured way of training. There are many people who just get trained how by looking over somebody else's shoulders. They just stand there, they just observe somebody doing it, and then they kind of like Ekalavya, they try to learn by themselves. But then there are a set of people who we actually, mentor them. We just train them. And so, you have to look at all these things. So with that, I think we will close this panel because
it's very simple in Kannada. We say that kuch vidada madve agala, madve agala kuch vidada.
Maybe you can translate for not
पागलपन हिंदी में बोले तो समझेगा? पागलपन छोड़ते वक्त शादी नहीं होती, शादी होने तक पागलपन नहीं.
So basically, you have to have consistent pregnancies. IVF, you know that it is subjective to a lot of factors. Appropriate diagnosis is important. Careful management at the clinical level is important. Consistency in procedure is important. Like you cannot do stuff at 35 hours and 36 hours, 37 hours, and then denudation after 1 hour, denudation after 4 hours. There should be some consistency in the procedures. Then there should be very skillful and trained and dedicated manpower, and then
document everything so that we can revert back and analyze if there is something good or bad happened.
You should also have realistic expectations because 42-year-old female with more than 90% defect, you cannot expect 60% pregnancy rate there. So you should know what is the total expect. Exactly, and then all these things. IVF as such is very traumatic for the patients, but then it need not be traumatic for the providers. We should enjoy what we are doing, and all these things would give you consistent pregnancy and it also let you enjoy your work. Thank you so much, Dr. Kanira, for this opportunity.
Thank you very much.
Thank you, moderators and the panelists for a wonderful panel discussion. And we are the hotel faculty will be picked up at 7. Please be in the lobby. If you don't make it to the bus, you have to take your own transport and reach the club. I'll share the location in both the groups, delegates as well as faculty group. Thank you again. I hope you had a wonderful time whole day. I'm sure you're tired. Freshen up and then see you again. And then you can hit the dance floor later. Thank you. Bye-bye.